Namaste and greetings. I, Reetlath, researcher at IMPRI, Impact and Policy Research Institute, Prabhav Evang Niti Anusandhan Sansthan, Nai Delhi, extend my warmest welcome to you all to IMPRI Web Policy Learning. Today marks the inaugural day of Women's Sexual and Reproductive Health Across a Lifetime, an online national summer school program, a 4-day immersive online certificate training course. This training program is organized by IMPRI, Gender Impact Studies Center. So let's begin with a brief overview of the program. Our course stands as a beacon in the evolving landscape of gender studies, delving deep into the intricate realms of sexuality, reproductive wellness, and personal autonomy. With a keen focus on empowering individuals, particularly women, to navigate their reproductive journeys with confidence and agency, we explore a myriad of topics, from the critical stages of adolescence to the transformative phases of menopause. Throughout our journey together, we will unravel the complexities of menstrual health, maternal care, contraception, and family planning, while also addressing the vital intersections of transgender rights, mental health, and aging with the realm of productive discourse. Whether you're on the brink of diving into a healthcare career, passionate about public health advocacy, or simply eager to broaden your horizons and make a meaningful impact on women's health, this program offers a wealth of benefits. With that being said, I would now like to introduce the chairs of this event, which are Professor Vibhuti Patel ji, Visiting Distinguished Professor, IMPRI, and Dr. Manorama Bakshi ji, Director and Head of Healthcare and Advocacy, Konosia Adversary, Founder and Director, Trilok Raj Foundation, Visiting Senior Fellow, IMPRI. This program also has an excellent panel of experts who will be sharing their expertise for the duration of this program. The overview of the program time structure is as follows. So on day one, we have a session on constraints to choice, shifting paradigms in reproductive autonomy by Professor Mala Ramanathan ji, followed by a comprehensive maternal care, pregnancy to postpartum by Professor Vina Vaswani ji, which is followed by Understanding Sexual Health, Navigating Consent, Legalities, and Women's Health by Dr. Padmaja Samant-Mavani ji, which will be followed by a session on the participants' introduction conducted by the IMPRI team. On day two, we have Guiding Adolescent Health and Nutritional Well-Being by Dr. Kamakshi Bhate ji, followed by Adolescent Changes, Body, Mind, and Society by Dr. Anamika Priyadarshini ji, which is followed by Menstrual Matters, Health, Stigma, and Solutions by Swati Rane ji, Dr. Swati Rane ji. On day three, we have a session on healthcare systems and gender-based violence by Dr. Padmaja Samant-Mavani ji, followed by Integrating Menopause, Mental Health and Aging by Dr. Anuradha Sovani ji, and we will conclude the session with a session on reproductive rights of transgender persons by Dr. Aska Sheikh ji. On our last day, which is the fourth day, we have a session on contraceptive advances, STD prevention, family planning and awareness by Dr. Sangeeta Reggie ji, followed by abortion and consciousness, objection, ethics, law and reproductive rights of women by Dr. Amar Jeswani ji, followed by assisted reproductive technologies by Dr. Anant Bhanji, followed by preventive care addressing RTIs, UTIs, and cancer risk by Sanjita Arora ji. This will be, and then we will be concluding our entire course with a feedback session and shares closing remarks. The panel of convener comprises of Dr. Simi Mehta ji, CEO and Editorial Director, IMPRI, and Dr. Arjun Kumar ji, Director, IMPRI. Proceeding further, I welcome all the participants to this enlightening deliberation and thank you for being interested and putting your time, energy, and efforts into understanding emerging issues pertaining to women's sexual and reproductive health, while helping us to bring together the practitioners and participants through this course for impactful policy research and action. We have also shared the course outline and reading resources in your email for your kind perusal. Before I start today's session, I would like to remind the housekeeping announcements once again. Please join the meeting on time. There will be a Q&A session after each presentation. Share your questions on the Q&A box. The questions must not be posted as anonymous attendee. Ensure that your questions are precise. And lastly, refrain from making general comments in the question to save time. Now, without any further ado, let's start our program. It is my honor and privilege to invite our co-chair for the program, Professor Vibhuti Patel ji, to start the program with her opening chair remarks. Ma'am, you're on mute.
Thank you, Reet, for introducing the course. And I express my heartfelt thanks to Dr. Arjun Kumar, Dr. Simi Mehta, Ms. Priyanka Negi, Vaishali Singh, and Reet for putting this course together. And also welcome my co-chair and also Professor Ramanathan, Professor Vina Vaswani, and Padmaja Samant-Mavani, and esteemed participants. Sexual and reproductive health issues have been extremely important for the 21st century women, and that's why this course was there on a popular demand. And we know that as per WHO's definition, SRH means the right to healthy and respectful relationship, health, and getting good health services which are inclusive, safe, appropriate, and access to accurate information and effective and affordable methods of contraception, access to timely support and services. They are extremely important. And when we talk about health, it is sexual health. It is not only physical health, but mental and social well-being. They are also included. WHO has defined sexual health as a physical, emotional, mental, and social well-being related to sexuality. It is not merely absence of disease or dysfunction or infirmity, but sexual health requires a positive and respectful approach to sexuality and sexual relationships, as well as the possibility of having pleasurable and safe sexual experience free of coercion, discrimination, and violence. For sexual health to be attained and maintained, sexual rights of all persons must be respected, protected, and fulfilled. It was in the 70s that the women's movement started taking up this issue when it started fighting against various forms of patriarchal control over women's sexuality, fertility, and labor. When we talk about the good sexual and reproductive health, when we talk where we talk about the safety is extremely important. UNFPA has evolved a reproductive well-being framework which rests on four pillars, namely autonomy, control, respect, and system of support. So reproductive health refers to the condition and state of reproductive organs and concerned behavior in the individual. And that's why we say that the question of sexual rights and sexual autonomy has to be extremely important agenda for women's dignified life. After 1990, there has been a paradigm shift from reproductive control to reproductive rights. The new reproductive technologies with its four functions of, say, contraception or assisted reproduction, genomics, and population stabilization, I think all of them we have had so many experiences of gross violation of human rights of women. We have seen increasingly all the population stabilization policies are targeting women, and the issues which have been very controversial have been unsafe imposition of unsafe contraceptives in the developing countries, conditionality which is put by the international organizations for getting any kind of aid, and we have seen extremely dangerous ramifications in Africa, Latin America, and also several Asian countries which came under the framework of enhanced structural adjustment program. So when now the focus of this course is on women's sexual and reproductive health, which is related to multiple human rights, including right to life, right to be free from torture, right to health, right to privacy, right to education, and prohibition from discrimination. And even when it comes to United Nations Sustainable Development Goal, SDGs have explicitly recognized sexual and reproductive health and reproductive rights as essential, not only to health, but also to gender equality and wider social and economic development. Thank Thank you very much.
Thank you so much, ma'am, for setting such a positive tone for today's session. Now, I'm delighted to call upon Dr. Manorama Bakshi ji, the co-chair of this course, to share her opening remarks with the audience.
First of all, thank you so much. Thanks, IMPRI, for giving me this opportunity to co-chair this very pertinent topic. And thank you, Professor Vibhuti, for setting the key background to this course. As we embark on this journey for next 4 days, let's keep in mind that the significance of addressing the sexual and reproductive health across all stages of women life. I think the insights and discussions will be very, very extremely useful to make a real difference. Since I come back from the background of Ministry of Health, I need to put it across here that India was the first country across the world to have launched national program of family planning in 1952. And since 1952, all these decades, the program has actually gone a lot of transformation in terms of policy and actually implementation on ground. And now, beyond the population stabilization, we are today talking about the reproductive rights, the sexual rights of the women, and more emphasis on reducing the maternal mortality, infant mortality, and morbidity that it causes. We are again looking into like addressing how we can influence it, not as a population, influencing population growth, but looking it from the unmet need of the family planning. That's one of the imperative components that Ministry of Health is currently looking into. Even though like we have the basket of choice for the females, but irrespective of that, almost 10% of the NFHS 5 shows that unmet need is 10%, which means if we are having almost 3 crore females getting pregnant every year, that goes almost like 21% of our whole cohort. 21 lakh women still need their contraceptives. So that is something that we need to look into. When we talk about the age in childbirth, in India still, as per NFHS 5, we have almost 24% of the women who still get married below the 18 years of age. So again, these things need to be discussed both at the ground level and in the policy corridors, because there are certain states, like whether we are talking about Bihar, Rajasthan, Bihar, we are concerned about because 40% of the girls get married before 18%, as per NFHS 5, Rajasthan 25%, Jharkhand 32%, UP 15%, and MP 23%. These are the some of the percentages which we need to look into. Then another issue that we talk about, because if we want our babies to be healthy and if we really want good health across and we want babies to survive, then spacing is very important. So I see healthy spacing of 3 years that Government of India is propagating, and definitely it is the women's choice, but we need to counsel. We need to have the choice of contraceptives for the women. Then ultimately it is women's choice. If she's educated and empowered to take these decisions, I think this course will delve into these kind of things. And over a period of time, I am excited that there is an esteemed panelist and they are so much well known and qualified, and it will be a meaningful dialogue for all of us. But since I have worked in HIV/AIDS domain for almost a decade, so I also see that the reproductive rights and sexual rights of women in very different ways, whether we are talking about the transmission, we are talking about the equality or stigma and discrimination, which still there exists. So how through policies and through laws we can look into these factors. And to end, I would like to say that women's reproductive and sexual health requires a comprehensive approach, actually addressing the basic underlying factors, social, economic, gender inequalities. We need to look at those parameters as well. Thank you so much, Reet, and over to you now.
Thank you so much, ma'am, for setting such a crucial background and tone for our discourse today. Now it is my invite Professor Mala Ramanathan ji to start the program with her keynote address on the topic From Constraints to Choice, Shifting Paradigms in Reproductive Autonomy. We welcome you, ma'am. If you could please take it over.
Thank you. Vibhuti ji and Dr. Manorama Bakshi ji and the whole IMPRI team for letting me take the opportunity to be the first person to speak. And I also recognize that with my friends on the panel, Dr. Vina, Vaswani and Padmaja Samant-Mavani, I am in a very, very illustrious company. And for me, that is here a real honor to be amongst all of these people speaking on this issue, from constraints to choice and shifting paradigms in reproductive autonomy. And for discussing this, I cannot be more grateful to Dr. Bakshi and Dr. Patel for having set the tone in terms of one, introducing the evidence base, one of them that is a National Family Health Survey, and also giving us a comprehensive context within which this paradigm shift is occurring from the 70s to the present moment when, you know, the discourse on reproductive rights had been center staged, sometimes forgotten, sometimes, not almost at the center, but always as technology develops, has been pointed out by Dr. Bakshi, we need to reiterate newer forms of reproductive autonomy. And that is why... Can I continue? Is it?
Yes, ma'am, please go ahead.
Yeah. So we need to reiterate new forms of reproductive autonomies in the context of rapidly changing technology and policy, which is trying so hard to catch up. And even in those contexts, Dr. Bakshi pointed out that India was the first country to have a family welfare program or family planning program way back in 1952. India is also one of the very few countries that in some sense liberalized abortions using the Medical Termination of Pregnancy Act in 1971. And we have had, excellent support from the Indian judiciary, which has constantly risen to the occasion to facilitate access to abortion for women in different contexts and different circumstances. And yet, constraints persist. And that is why I have selected this in order to highlight some of the issues in moving from constraints to choice. At the start of this option of having reproductive autonomy for abortion, it was maternal mortality that was, and the OBGYNs who were on the forefront of, liberalizing the laws surrounding abortion to the extent possible. And that is why it's ironic that the restrictions on access are also coming from the same people. And that's precisely why I'm going to talk about that if we need to enhance choice and restrict the constraints or remove the constraints, we need to work with multiple stakeholders, including the OBGYN people, to facilitate this. My disclaimer, as I work in the Sri Chitra Tirunal Institute, the opinions expressed in this presentation are my own and do not represent those of the institutions to which I am affiliated. So I aim to look at access constraints for reproductive health services for women using the example of medical termination of pregnancies from NFHS data to look at the demand side and to describe some of the provider-based hurdles that comes in the way of women's exercise of this reproductive autonomy, especially with regard to abortions, and to suggest some possible solutions for them. So, now there may be some people who have lived in a world where NFHS is not common, and therefore I thought I should set the stage. The NFHS National Family Health Survey 5 was conducted in it's wave 5, so it's been conducted on a continuous basis from 1973, 72, 73. And in the present version, it was in 28 states and 8 union territories, covering 707 districts across India. It covered 636,699 households. And in this, data on women's reproductive history was collected from all eligible women who are aged 15 to 49. That's because they are treated as women in the reproductive ages in these selected households. And it included only women who stayed in the household for the night prior to the interview. Therefore, we have 7,24,115 eligible women, and the data collection went on from 2019 to 21 because of the delay caused by the interruption of the COVID pandemic and the prevailing conditions. This questionnaire has been responded to by these women, and the indicators provide information at the district level. But for some special issues concerning women, only a subsample, such as when we wanted information on husband's background, women's work, empowerment, health issues, domestic violence, the number of women reduced to 1,08,014 women. And the men's questionnaire was responded to by 1,01,839 women. And that becomes important for me because of the data constraints, because I'm looking at men's attitudes to women's reproductive autonomy as well. So the sample sizes, that is why it gets restricted. And therefore, when I describe the context in which abortion is accessed, I would consider only state level inputs, because these indicators are valid only at the state level. Therefore, I am looking at the restrictions to access to abortion that obtains at state level by looking at use of abortion across the states of India and the state level environment in which that happens. So if you look at it, the percentage of pregnancies that ended in an abortion in urban areas was 4%, and in rural areas, it was 2.5% of the total number of pregnancies. Now, if you look at mothers schooling, there is the more the education, women who are knowledgeable and are able to exercise their autonomy, such as those in urban areas, such as those with 12 or more years of schooling, and such as when the religion doesn't impose some forms of restriction on their ability to exercise, such as in those contexts, you find that women are able to access abortions when compared to rural women or women with no schooling, or when compared to women who may have certain religious restrictions on their ability to access abortion. Now, again, when we look at caste, you can see that women from other castes are likely to have higher rates of abortion. And if you look at the highest wealth quintile when compared to the lowest wealth quintile, that pregnancies ending in an abortion are higher among those. But so it's not only educational access, it is also financial access, which women are able to either go for transport or find the right facility, which comes from both education, physical space which they occupy, such as urban areas, the mind space that they occupy that does not restrain the access or use of abortion, and financial access that comes from the household wealth that they have that shapes women's ability to take recourse to abortion. Now, if you look at it across the states in urban and rural India, what you find is a varying scenario, with it ranging from 4% to around 5+ % in Delhi, and close to 4+ % in Odisha, to close to 10+% in Manipur, and northeast states have higher utilization of MTPs. And if you look at the southern states, there also you have higher levels of utilization of MTP facilities. Kerala, not very high, but then the contraceptive use in Kerala is higher, as it is though the contraceptive of choice is sterilization and not spacing. And that is where what Dr. Bakshi pointed out about the unmet need comes into play, because in many of the South Indian states, regardless of various other things, the unmet need for particularly spacing methods is high. So if you look at state level, percentage of women 15 to 49 ages whose last pregnancy in the 5 years preceding the survey, they report unplanned pregnancy was the reason for abortion is not less. So I used these variables. Then I looked at percentage of men aged 15 to 49 who agree that contraception is women's business and a man should not worry about contraception, to look at the extent to which male responsibility for contraception is eroded, percentage of currently married women with an unmet need for spacing that determines access to contraception, and currently married women with an unmet need for limiting, that is for permanently limiting family size. Now, I used those variables and looked at the associations with pregnancies which were terminated, and what do I find? I find that the unmet need for spacing is what is negative. So lower the unmet need for spacing, higher the abortion, which seems very counterintuitive, but I will come to that. And if in a place there was a higher proportion of men who agreed that contraception is women's business, you had lower levels of women taking recourse to abortion. Now, while that is counterintuitive, look at the option 5, that when there was higher utilization of spacing methods, women who reported unplanned pregnancy was higher, and so was the percentage who had unmet need for spacing. If you can see, that is also very significant, which actually tells you that in states where a higher proportion of men believe that contraception is a woman's responsibility, the unmet need for spacing among women is low. It's negative, but statistically significant, and this is very strong. In those states, this is to tell you about the environment in which MTP is exercised. Very, very restrictive. In states where the unmet need for spacing is low, use of abortion is relatively high. And when I regress this, the regression model actually explains close to 22% of variation in abortion levels, which means spacing, utilization of spacing is a very significant determinant of the demand for MTPs. It doesn't make sense when I say this unless you realize that unmet need for spacing looks at non-use of contraception. That means they are not using contraception, and they have a mistimed or unwanted pregnancy, and it is not actually the physical access to contraception. In states where there is a higher percentage of women stating unwanted pregnancy as a reason, the unmet need for limiting pregnancies is also high, means their access to contraception is abysmally poor. That is why when unmet need for spacing is high, unmet need for limiting is also high, and vice versa. So what does this indicate in terms of access to abortions? Where a high proportion of men believe that contraception is women's responsibility, what you find is unmet need for spacing among women is low, but abortion is high. States where a higher proportion of women say unplanned pregnancy is the reason for abortion are also states with high unmet need for limiting. This means absence of male responsibility and limited access to contraception for spacing and limiting pushes women into looking at abortion as a means of spacing. And that is where they come a cropper, because all of this is also tied to male responsibility. Now, I told you about the gendered context in which there is a demand for MTP services. In a context where male responsibility is abysmally low, access to spacing, meaning there is an unmet need for spacing and also limiting, is the place where women take recourse to abortions as a means of actually spacing. Now, when one of my students undertook a study on OBGYN's reasons for not offering MPPs, that is where I realized there was an added layer of health system barrier to MPP services across states. This was a study where attitudes of MTP OBGYNs, 108 OBGYNs were examined in 2 districts of Kerala, and close to 68% of the OBGYNs did not have a very favorable attitude towards MTP, provisioning of MTP services. And they found ways and means to actively resist offering abortion services. One of the reasons why OBGYNs resisted provisioning of services, even when they were in context like government health systems, where provisioning of MTP was mandated by law, was a religion related, because religious teaching and religious tenets act as a barrier to particular OBGYNs providing MTP services, and they very discreetly avoided services through various means. One of the means they used was to recommend someone else to do it within the same system, or make it an opportunity for the residents to learn. Then there was emotional resistance among OBGYNs, and this is a qualitative study. So the emotional resistance came from, advocating for women's autonomy, and finding that in spite of all of their efforts at such advocacy, women don't take recourse to contraception. And that reason should be very obvious to those of you who have seen the data. The supportive environment that is needed from partners is simply non-existent all over India. Given that, no matter how much the healthcare provider pushes for the women's contraceptive use, either lack of access to spacing methods or inability to use spacing methods because of unsupportive partners comes in the way. And that the OBGYN reads as women resisting abortion, and therefore they get tired and they decide to not to offer MTP services. The other one, which many studies are reiterating to me, is actual limited understanding of the requirements of second trimester MTP provisioning. So there were limited facilities in the hospitals with the professionals work, especially primary health centers, where you need, under the law, 2 OBGYNs to be able to offer the services. Therefore, many OBGYNs could only offer first trimester abortions. Then there were institutional barriers. One was religion-related resistance, which I talked about, which was largely individual-based. That is the individual OBGYN's own resistance. But there were also institutional policies that do not allow for the provisioning of MTPs, and that acted as a barrier regardless of what the medical provider thought themselves. And last but not the least, here was a definitive barrier to offering services, and one came because there were severe threats to offering MPP services in that environment, personal threats and professional challenge if the particular professional offers the services. It could be things like that person is not a good provider. OBGYNs have to offer, delivery services, more positive services, and MTP was seen as somewhat of a lesser service, and that served as a threat. When I say threat, I don't mean someone came, like it is reported in the United States of America, to threaten the providers, but it threatened their professional stature and diminished them in the eyes of their peers as doctors who offer abortion instead of doctors who offer, caring things like infertility services or delivery services or difficult delivery services such as C-sections and things. And that is what led to also resistance to offer MTP services. So if you look at it, the training, the limited training to manage second trimester, institutional restrictions, and an environment that, the personal barriers that act, all of which limit the knowledge and experience and the demand for MTP services. And then women themselves come there with demand for services for MTP because contraceptives have failed and they are without a choice because often they take recourse to, rhythm and other methods because spacing methods that they so desperately need are also limited in access. And all of this builds up a resistance to offering MTP services, resistance among the OBGYNs. And if who has to provide MTP when a woman needs it? It has to be the doctors, the OBGYNs, and that if they are resisting offering MTP services, then women's access to MTP services is but naturally restricted. And I am not talking only on the basis of qualitative research from Kerala. An All India survey by Ayavu et al. In 2018, actually, the researchers reached out to 2,000 OBGYNs and 766 people responded. They presented a case scenario to healthcare providers and asked if they would provide MTPs for a 17-year-old unmarried girl accompanied by her grandmother who was 16 weeks pregnant. And this is barring the unwed status. For 16 weeks pregnancy, MTP is allowed, provided the guardian gives permission. More than half, 55.5% of the providers declined to perform the procedure. Now, therein lies the quantitative evidence to what I was saying, that people do decline, and I give you the reasons for why they decline. But I have numbers now that more than half decline. And but the good news is at least 2/3 agreed to refer them to a provider who would. And they would, but they also had a lot of caveats. When they were willing to offer services, they would ask for proof of age, which is not required. A woman only has to self-declare her age, and proof of guardianship, that is the person accompanying is really the guardian, which goes back, do you understand the resistance due to fear? That again comes back on why they put so many roadblocks. This is not at all required. And what was also very evident in that is only 46.7% actually understood the changing scenario and the medical legal aspects of the abortion law. And this should have gotten worse because there were amendments in 2022 again to the MTP Act. So reproductive autonomy, should we want to move from constraints to choice? What I recognize is it should not. We have some of the most progressive laws in the world. Reproductive autonomy of women is still constrained. It means we should not only depend on the law and its enforcement. The health system needs to be clear about the nature of services, particularly in something that is as sensitive as sexual and reproductive health services that it offers. And for each of the services, it needs to have legally valid SOPs that care providers have to follow. It cannot be left to the whims and fancies of choices of providers alone. If there is a law of the land with regard to this that needs to be enforced, the only way to do it is through standard operating procedures along with the law. Women need to be also made aware of the services they can use and places where these are available, including contraceptive services, to avoid the need for abortion. And these For married women, if we look at NFHS data, is strongly gendered by partners who are very, very unsupportive, which is what gives rise to the need for abortion or MTPs to be used as a means of spacing. Again, for women's reproductive autonomy to be respected, healthcare providers again seem to reflect the societal norms and contribute significantly to restricting choice spaces for women, particularly reproductive choices. They need to be educated. The providers need to be educated on the law of the land and their duty to provide and enforce it. And you will find that Dr. Jasani, who is going to speak on the fourth day, takes up the issue of conscientious objection to provisioning of services, which is the other end of the spectrum. In addition, medical curriculums include provisioning of services, but what they don't address in great detail is the legal aspects of health services and also the need to respect the rights of patients who seek these services. And that also seems to be a need for the hour, given the evidence that is emerging on knowledge of legal aspects. I have talked about the kind of demand side restrictions that are emerging with regard to women's access and exercise of reproductive autonomy with respect to MTP services. I have talked about supply side restraints that are emerging as a consequence of, self-restrictions taken up by the providers themselves, which affects the supply side. And therefore, if reproductive autonomy and choice needs to be exercised, some of the suggestions that seem to come from the evidence is what I have suggested by way of having standard operating procedures that are uniformly well known, enabling access to contraception, educating healthcare providers not only on the ways to provide MTPs, but also the legal aspects of it, and include this in the curriculums with greater clarity so that when we have trained professionals, they are conscientious, legally aware, and sensitive providers, particularly enabling women's choice and autonomy.
Thank you so much, ma'am, for such a comprehensive presentation. I believe I speak on behalf of everyone when I say that your insights are not only enlightening, but also deeply inspiring and igniting a sense of important reflections among all of us. So thank you so much, ma'am, for your time and wisdom. Now, I would turn to our co-chairs for the event, Professor Vibhuti, ma'am, and Professor Manorama ma'am, Dr. Manorama ma'am, for their remarks and comments on the session. Meanwhile, the audience can type their questions in the Q&A box or raise their hands for the questions.
Thank you, Professor Mala Ramanathan, for such a comprehensive presentation backed by statistical base, and also you as a statistician and working in the field have come up with a very robust data analysis. My only question is that what can be done as a preventive measure? Because most of the cases when we go to the abortion clinic, abortion department of the civil hospital or government hospital, you see so many teenage girls who are there. And when it comes to school education, we bring the moral arguments and don't the use. I remember having discussion with the authorities who said that they will lose their innocence. Already their innocence is lost out. What can be done to see to it that these young girls, and there is a mandatory reporting also, that is one of the reasons why doctors are refusing to perform any abortion on the young girls. And then they go to the quacks and the backdoor abortions take place so many times they are fatal. So I think this is a very important concern about which I think all policymakers need to pay serious attention.
Ma'am, that is a very, very important restriction that is emerging. But, the restriction abortion, the need to report can be taken, it's not so much as a restriction as much, and I was listening to various legal opinions on this when the new amendments came up. And one of the things that was stark, as reported by the legal luminaries on the amendments in the intersection with POSCO Act and the need to report, particularly for under 18 women, is you can take the consent to not to report also of the guardian. If the guardian says you can't report, then you don't have to report. So that protects the provider from all these things, and they have to only maintain some kind of a register or something. And we need to get that legal knowledge and these intersections and get clarity in unequivocal terms to the OBGYNs through their professional forums and various other things, madam, before, their myths, the myths that were created in the olden days are dispelled. You have to give them also solutions.
Yeah, that's important.
Ma'am?
Thank you so much. Thank you so much, Mala ma'am, for this very illustrative presentation. And thanks, Professor Vibhuti Patel ma'am, for raising this very pertinent question. I see it since I have the experience of ground, I will share some of the things because Professor Mala, she spoke a bit on the involvement of religion sometimes in influencing their attitudes and policies, especially regarding the MTP. My experience has been overall in the reproductive health, because when I was working in Mewat, all the when it comes to the contraceptive choices that were actually being shunned for a very long time. And I remember like way back in 2000, I think it was 14, 15, when I was traveling in Mewat and I visited a lot of like mosques and other places wherein I said that why the contraceptions are not taken up by the women, because total fertility rate was quite high, around 5 to 6 was the TFR at that moment of Mewat. And then I came to know that only injections are permissible in certain religions, and that is how we introduced DEMPA, Antra, actually, in around 2016-17, that was introduced from Mewat. So I have seen not only within one particular communities, but across. Number second, ma'am, I have seen like when it comes to the MTP, I'm sharing the experience of like Telangana, Rajasthan, areas wherein the people know that two-child norm. So people used to young girls. I have seen especially that in Mehboob Nagar, Adilabad, wherein the young girls, they had the two babies and by 22, 23, they would be sort of like done with it. And wherein we could never see the male sterilization happening, but female sterilization was so common. And I have seen that vis-a-vis that, like when it was very common, I mean, people not taking care of tuberculosis, even though like it is something, but it is irreversible. Women taking maybe decision because of the family or
Can you hear Manorama, madam? It's not me, no? No, I can hear went away.
So ma'am, till Manorama ma'am's internet connects back, can we take some questions from the audience meanwhile?
Yeah, there
Very
were a couple of questions. I think.
So first of all, there's Shifali ji. You can go ahead with your question.
Hi, am I audible to everybody?
Yes, please.
Yes, thank you. Thank you. So, thank you for such an insightful talk. My question is to everybody, and especially Mala ma'am. As you said that there was a incident where a 17-year-old girl had come with a grandmother. In that case, in today's generation, when we talk about right of young adolescent women, especially those who are below the age of 18, and on the other hand, chapters on reproductive health is being removed from NCERT syllabus, how can we take a stand as when we talk about gender equality, how do we initiate a conversation or dialogue with not only amongst the doctors, but also amongst with the policymakers and education system? That is my question.
I think that we need to initiate that conversation. And while policymakers, see, very often what we fail to understand is identify allies, no? Allies in education. We are always looking at OBGYN, we are looking at health policy people. But I found when I go into the communities that the education department, particularly the +2 education teachers unions and others, even though they are a bit diffident about having to take up reproductive health chapters, many schools, actually the chapter may go away, okay? But they have alternate spaces and they can be excellent allies. In creating those spaces, making a pitch, we need to find allies outside our circle who will also speak up. And, the sexual and reproductive health rights came from a rainbow coalition at the 1994 ICPD. Rome was not really built in a day. So when we need to do advocacy, we need education department, people who are affected by the consequences. See, so many teachers' heart break when they find that one girl can't continue her education because her parents take away because she got pregnant or she runs the risk of being pregnant. So we need allies among men partners, men advocates. We need allies from all sides, including education department. We need to espouse this cause from a multi-sectoral perspective. That may help, but we also need to involve men. I don't know how to do that, but male contraceptive responsibility, educating young men on responsible reproduction, which means going back to educating young men and women, finding alternate spaces. Something comes back to me. Many, 30 years ago, in rural Tamil Nadu, women did not complete +2 education and they went for informal sector employment. We can't just be advocates. We created spaces, believe it or not, 3-minute to 5-minute talks in railway stations where they caught the train to reach out to those women. I don't know where is that railway station for the young women. One door may close. We have to find other doors because the policy environment will open one day, but can our young girls and boys wait till then? That's unfair. So we need to do many things. We need to find that railway platform. I don't mean a literal railway platform, but the metaphorical equivalent to talk, reach out to those young women, find alternative spaces. Maybe use social media, make it popular, support it. They access it. Find ways to reach out to them in a manner that is not a threat to parents or anybody. Culturally appropriate way of wording it. I mean, at people who sell white goods like soap, people who sell white goods like televisions, detergents do it. Why can't we? Sorry, I don't know if I answered it.
No, that's what the NGOs are doing. Women, community-based organizations are doing that only. For us, working with the boys worked. Inviting boys along with the girls in our camps in 20 bastis of Mumbai. That really worked. So it also prevented child marriages, and they don't allow sex education. So we had to call it personality development. Within that, we would give them the human anatomy and what kind of precautions that we need to take.
Now, in this mahol which we are talking, you know, many of the states you're talking about are doing Saas Bahu Sammelans now,
Yeah.
which is culturally inappropriate कि contraception का जिक्र सास और बहू के बीच में हो ही नहीं सकता. It's culturally inappropriate. But the Mission Parivar Vikas is asking for data on how many Saas Bahu Sammelans were conducted. So, I mean, we need to do a lot.
Yeah. Correct. Thank you.
Yes, thank you so much, ma'am. Just a note for all the audience members who are asking questions. Please do introduce yourself in a line before you ask the question. Yes, ma'am. So now, Saheli Chaudhary ji, you can go ahead with your question.
Good evening, ma'am. My name is Saheli Chaudhary. I am from West Bengal, Belda College. My question is similar to the question of the previous participant. That is, we should think about introducing sex education now as a compulsory part of the curriculum. And my second observation is that the way social media or media promotes contraception is at present, it reflects more of pleasure than responsibility.
Madam, for every one of those examples, and I think what you're saying is 100% correct. You know, they really are out there. Their purpose is to sell their product, no, madam. So, but you look at other examples like Menstruopedia, which, you know, there are so many social media documentations which come as cartoons and other things which reach out to women, convey wonderful gendered messages. The alternatives need also to be center staged because people do access them. And when there is no authentic material, we need to generate and put that material out there. And we fail there. No, it's not enough to just talk. We need to encourage creative ways of reaching out this information. And that's what I meant when I said no. And in the area of menstruation, it has been done beautifully and wonderfully through that whole Menstruopedia messages that came. So why not about sex education and finding out nice euphemisms which are reasonably innocuous but can convey the message? And we need to work on all of that, madam. You, as I said, no, Rome was not built in a day. And changing public policies, you know, in a restrictive space is not going to happen overnight. We need to struggle. And that's what I meant when we said we think the agendas are over, newer agendas open up. And there will always be different forms of fundamentalisms which affect rights of women, especially in the area of reproductive choice. So we have to keep trying and trying and trying, because I know it's like you cross one mountain and another mountain comes up. But that is why we need to educate, you know, across the board. We need to bring in men on board. We need to keep trying.
Yes, ma'am.
Thank you.
Thank you so much, ma'am. Our next question is by Nikita Sharma ji. You can go ahead. Oh, yes, Nitika Sharma ji, you can go ahead with your question.
It's written in the question box.
I'm audible.
Yeah.
Yeah.
Yes, ma'am.
Good evening, ma'am. Nitika Sharma from Himachal Pradesh. I'm PhD research scholar in HP University. Ma'am, my question is there any difference between sexual and reproductive right? If yes, then what about legislation if we talk about sexual right? Because when we use this word, society still consider it as a taboo and hesitate to talk in this matter. Even intellectual class has same attitude. So, ma'am, please your views on this.
See, way back when we talked about reproductive rights, we realized the sexuality connection to reproduction, ignoring it was a major pitfall, because a significant portion of reproduction is through sexuality, which cannot be wished away. And all of the restriction on reproductive rights that you actually see in terms of contraceptive choices comes from restrictive policies, which, when I say policies, I mean social restriction on the sexual rights of women, saying that they should be married early so that their, this ritual of marrying, giving hands of girl in marriage to somebody, maintaining this virginity kind of issues come up. And that doesn't make any sense in the changing world today. And that discourse hasn't resonated with many of the senior policymakers and those who influence those policymakers. So there is a need to continuously articulate that there is no reproduction without sexuality. And therefore, the sexuality connection needs to be re-emphasized from at least a perspective of, right, something as simple as age at marriage. People are willing, we need to find innocuous ways to get in sexual rights. Right to choice whom to marry is as much a financial choice, an economic choice, as it is a sexual choice. Right to not to marry is also a choice. When we talk of right to sexual pleasure, very often someone pointed out that it descends into pleasure. But does that discourse talk of sexual pleasure for women? And that is why, the sexuality connection becomes important. And exercise of choice. Where and with whom to beget children is as much a sexual choice as it is a reproductive choice. And therefore, these are equal rights. There isn't one without the other. And we need to keep saying it again and again, loudly and clearly, and in simple ways. Often I find that those of us in the sexual and reproductive health movements take recourse to jargon. And हमें अपने आप को भी सुधारना चाहिए कि we don't do that. We should not use the words which came to us and, where as a part of progressing along that knowledge, we went somewhere. But every time we talk, we need to bring it down to simple language that can be universally understood and give simple examples. We shouldn't use only jargon. We need examples. Sorry, I may sound very rhetorical and repetitive, but I don't even know if I'm responding.
Thank you. Thank you.
Thank you so much, ma'am. I believe Neelam ji wanted to add some points of her own. So, Neelam ji, you can go ahead with that. Okay, I think she got cut off. So, now looking at the time constraints, we will be concluding this session. So first of all, I would like to sincerely thank Mala Ramanathan ma'am for her address and for taking out the time to answer all the questions in such great detail and with so much patience. We are truly honored to have had the opportunity to learn so much from you, ma'am, and we're truly inspired by your commitment to promoting gender equality and reproductive rights. Thank you so much for your time and wisdom. We look forward to the opportunity of welcoming you back in our future events.
Thank you very much for giving me a chance to be among such an eminent panel. I'm really sorry I'm going to miss this wonderful talk, but if I don't go home and it rains, I'm in knee-deep water.
I know, I understand. You are in Kerala. Okay.
Yes,
Yeah,
ma'am.
please try to join. Yeah.
Thank you very much.
Thank you so much,
Thank
ma'am.
you.
Now, I'm privileged to call upon Professor Vina Vaswani ji to expand our knowledge on the topic Comprehensive Maternal Care, Pregnancy to Postpartum. We welcome you, ma'am. If you could please take it from here.
Can you see the slides?
Yes,
Yeah,
ma'am.
this is
Yeah.
fine.
Okay. At the outset, I'd like to thank the team IMPRI and Vibhuti madam who literally pushed me into this, because had it not been for her, I would not have been much what you call conversant with the issues at hand from gender perspective. I had a lot of experience from forensic perspective as also as a postpartum center medical officer, but I had not had an exposure to discuss gender issues, and it's only largely because of Vibhuti madam I took it up, and now I really do think that I have in discussion developed a better insight into the issues, and I can bring out the complexities that I have faced squarely and fairly to this discussion. So with that, when I'm talking about the sexual and reproductive rights, especially comprehensive maternal care, pregnancy to postpartum, I'll be touching upon the maternal mortality, the global as well as the Indian perspective, and also certain statistics. And in short, about the antenatal care and what happens to that, and how is the labor room management, and also what happens whenever a lady has delivered, the breastfeeding practices, and the support that's available. One, the support that's available in the hospital per se, but also the government, from whether it's a contraception or breastfeeding or all the facilities available, made available financially as well as support wise. And then we'll also be talking about the government schemes, innovations and challenges. So it will delve into comprehensive care required for mothers from pregnancy to postpartum. It will address the various issues of maternal care, including antenatal, delivery and postpartum care. Many a times we understand from our cultural perspectives, people think delivery is a natural phenomenon, that you don't have to go to hospital, you don't have to seek anybody's help, you don't have to do anything. And this is one of the reasons why people are deprived of care. The thought processes where, a small fever, a large, not even a significant fever, but a mild fever in a boy or a man pushes them to hospital. But events like pregnancy, postpartum bleeding are many times considered normal. So we need to look at why is this difference? Anything that is to do with females, it's expected that she's hardy enough to bear through, and naturally nature has endowed her with that kind of immunity to overcome. And that is how we have losing out on young mothers giving up on their lives because they don't get the timely care. When they do come for the care, the hospitals may not give the they cannot provide the care because she's having some of the she comes under the scheme and the government hasn't paid her, or any of these issues. When we look at, first we understand process as well as the complexities that go with it. So maternal health is a cornerstone of public health and a societal well-being. Ensuring health and well-being of mothers during pregnancy, childbirth, postpartum is very vital. Many times the moment there is a delivery, there's a huge urgency to take the mother home. And more important than that, even the breastfeeding has not been established. The vaccination is not complete. But by rushing like this, then the care of the mother is compromised. Maternal care directly impacts maternal mortality rate, infant health, and also the family outcomes. Maternal health refers to condition of women throughout the pregnancy, childbirth, and immediate aftermath. So these are three stages, one transiting into another, but they're also in continuity. In India, maternal health landscape reflects huge progress, but also huge challenge, because the progress sometimes is lopsided. In certain states, it looks like everything is hunky-dory, but in some states, it takes a huge dip. So on an average, it is not that we have taken progressive steps forward, but there is a lot of uncertainties of whether we have made a huge progress. Maternal health indicators are crucial markers of nation's development. So when we talk of MMR statistics, maternal mortality rate statistics, it reflects the number of deaths of the mothers soon after delivery in 100,000 live births. That means how many deaths take place per 1 lakh population. So despite the improvement, India is still facing challenges in the maternal mortality rate. What are the government figures like? What do they indicate? And how are we in relation to the government figures? Because from 2000 to 2020, the global maternal mortality rate declined by 34%. There was a significant decline in the maternal mortality from 339 deaths in 1 lakh births to 223 deaths. According to UN interagency estimate, this translates into an average annual rate of reduction of 2%. Whereas in India, the maternal mortality rate for the period of 2018 to 2020, as per the latest national sample registration system, is 97 per 100,000 live births. Declining by 33 points, that is 130 for 100,000 live births in 2014 and 16. This translates into 8,580 additional mothers saved annually. It feels better because there are so many mothers saved annually. But then let us look at the nitty-gritties of the state-wise distribution also. 95% of all maternal deaths occur in low and middle-income countries. India is responsible for nearly 1/5 of all the maternal fatalities worldwide. That means a huge burden is contributed by India. And maternal mortality rates are relatively high in northern regions like Assam, Uttar Pradesh, Uttarakhand, Rajasthan, like 328, 292, and 255 per 1,000 live births. That means we suddenly see that the progress here is not something admirable. Compared to southern states like Kerala, where you have 66, and in Tamil Nadu, which is 90. So it does feel, when you look on a lopsided figure on averaging out, it's okay. But when you look at states, that means the states have not made the necessary progress. And MMR is influenced by utilization of maternal health care services. And these are the states where utilization of maternal health care services is not proper. It's not complete. Because when you say the antenatal service is utilized, then there should be at least 3 visits, 100 days of iron tablet being taken, 2 tetanus toxoid injections being taken. But if that falls short of it, then there is no cover that the mother is enjoying, nor can it be the same be responsible for the healthy birth of the child. For example, the percentage of institutional delivery is high among women from states like Kerala, where 99.4%, or in Pondicherry 99%, while it is low among Jharkhand. Of 100 mothers, only 18, about 18 mothers access hospitals. So can you imagine the huge number of mothers who don't access hospital care? They may go to A&Ms who come home and deliver, or somebody at home delivering. It's not a big thing. Sometimes you look at childbirth, but what happens after childbirth? What about contraception? What about placenta coming out? What about making sure all the products of placenta are out so she doesn't continue to bleed? So who looks after that? So is it just enough to say child is born, child is healthy, child is male, or child is female? But then still the mothers are left high and dry. So if they catch infection, especially if there are tears which are not sutured, it is responsible for septicemia and death. So, but then this is what happens if we do not access a proper antenatal care. That goes into postpartum care. In Meghalaya and Uttar Pradesh, it's again 24.5%. That means nearly 75% don't access antenatal care. So maternal mortality is critical indicators of countries' healthcare systems, women's well-being. And despite efforts made by Indian government through National Health Mission to address maternal health, there is a need for further research. Why? Why don't they access? Is it because of the belief that women, when they access healthcare, the care to the family is lost, they're not cooking, they're standing in OPD, and then we cannot afford to do that. They need to continuously be like factory workers, churning out food, caring for people, caring for elders. Is that one of the reasons? Because it is not to say that there are no hospitals, but still there is a problem with the access. There's a challenge of accepting the access. So significant reductions in maternal mortality rates, how do we get it? So the most accurate method of determining MMR is currently reproductive age mortality studies, RAMOS, to gather information about the demise of women of reproductive age. Several sources and documents are examined in the study. Additionally, number of fatalities is estimated through verbal autopsy. You know, no matter what statistics you do, unless the deaths are recorded which take place at home, you would not get a complete number. So then how do you get the deaths recorded at home is through verbal autopsy, where somebody visits and asks, when did the mother die after giving birth? Within how many days? Is it within 40 days? Or is it the first day or the second day? And what were the events that led to the death? Was there fever? Was there gasping? Was there bleeding? So to some extent, we are able to understand how it took place. In one of the research by Mohanty, it talks about the multiple deprivation of the mother. Women's recipient of antenatal care, medical assistant during delivery, and postnatal care across 3 dimensions of deprivation: education, wealth, and health. If you look at these 3 pillars, what about the education? What about the monthly income? And what about the comorbid conditions or general health? So in a study, he has shown that 32% of ever married Indian women reported being deprived in one of the 3 dimensions. 1 in 3. So it's a huge number. At least in one of the 3 dimensions, they are deprived, and 18% in 2 of them. That means whether it's education and wealth, or wealth and health, or in this combination. And 7% in all the 3. Education-wise, wealth-wise, and health-wise. So women deprived in all 3 dimensions were less likely than those not deprived to receive any antenatal care. If they didn't have education, they didn't have access to reach the PHC, and they didn't have a notion about health, healthy behavior, then they were less likely to come to hospital. So this is also a big number, 7%, and deprived in all the 3s. So women deprived in all 3 dimensions did not access, which did result in complications in labor, in childbirth, wastage of the child, and mother losing their life or developing long-standing complications and comorbid conditions. Differentials in utilization of maternal service across deprivation levels were higher in states where service coverage was low and lower in states where service coverage was high. It automatically says if ANC is well utilized, then the mother's health is better, because these are preventable. To a great extent, you can understand and put things in place. So it's like opening the door of the house when you have toddler has just learned how to walk. Won't the child run away? You have to make the house child secure. Similarly, we have to make the access possible for the antenatal mothers. Differentials in utilization of maternal health care service across deprivation levels were higher. So that is why we need to look at how best we can improve the services across all the states, across all communities, religious beliefs, and other things, socioeconomic status. What are the challenges and issues with maternal health care? When we talk of challenges and issues, first thing I would say, because I was a medical officer in a postpartum center, I gave contraception, and we also made sure antenatal checkup was followed. Everybody had a card, and that also showed the possible ultrasonography picture and how the mother was progressing. And during the delivery, we visited them. After the delivery, we forced contraception on them. It was not a very right way of doing things, but this was a part of the government plan, that they have to be given contraception before they're discharged from the hospital. Then if it were multi, like the 2nd or 3rd pregnancy, we used to put copper T. If it was after the 3rd, we used to insist on tubectomy or one of these measures. Now, many of them I realized, because I was also a vaccination officer, when I used to go in the these were the ladies who were supposed to come to us, they never used to come. Why? because they were afraid of our overpowering behavior of converting the multiple pregnancies into tubectomy. They were wary of us. They were afraid of us. So that is why the access to barriers can take different shapes. When is a rural-urban disparities. If they have 4 children, but they still want the 5th because they have only female children. Now, I cannot tell them, no, it's okay, make your girl IS officer, police, you don't worry, because ultimately she has to go back to her home and be kicked by her husband and in-laws if she doesn't deliver a male child. So one is the belief which allows you to access, and also the fear that stops you from accessing. Socioeconomic factors, poverty, education level, and cultural practices. Especially there are many elderly women who sit and say that people do a lot of fuss over pregnancy. Pregnancy, it is so natural. You don't have to go to hospital at all. So it's a socioeconomic factors also, and quality of care. When there is, in many of the PHCs, a lot of instruments are available, emergency OT is available, but doctors are not available. There's a significant number of shortage of well-trained doctors in the places, especially peripheral health centers, PHCs and PHU and CHCs. And also health risks of anemia, malnutrition, and existing medical conditions. Now, in the pregnancy, it's very essential that care of and mother and the child is taken into consideration. That's why comprehensive prenatal care involves medical checkup, nutritional support, and even lifestyle adjustment. What do we mean by lifestyle adjustment? Many of the pregnant mothers with a high blood pressure or hypertension, diabetes are not allowed to have a salt-free diet. Generally, they have to eat whatever is cooked for the whole family. They're not allowed to keep their feet up on a stool so that the swelling of the leg is reduced. No. She's not a lord or somebody that she can put her foot up. It has to be down. So such kind of behavior sometimes come in the role of mother's well-being. Antenatal checkup should be regular, and recommended frequencies is during the first 2 trimesters and increasing, especially in the last trimester, bi-weekly. And later on after 30 weeks, weekly checkup. So that is recommended. And also components of the checkup are physical examination, where you see serial weight gain. You also see fetal monitoring, fetal heart sound. Ask the mother to check for quickening, whether the child is moving around. If the quickening is not seen, then immediately report to hospital, and also screening tests and counseling. So diet recommendation, what is the iron, folic acid, calcium, protein, and essential vitamins. One is in the form of food. Second is also advice. What can be done, how to cook green vegetables, how to make sure that you don't cook it so much and take it with milk or something that oxalates don't get absorbed, calcium doesn't get absorbed. So these are all the recommendation, dietary advices one has to give, and exercise and the prenatal care. This is something that we are still lacking in Indian context, where we do not talk much of the moderate exercises a pregnant lady has to do. Recommended exercises, benefits of exercises, and precautions and contraindication. When it comes to natural, normal pregnancy is different, but high risk management requires more care. And during that, we have to identify the high risk case, identify the condition, talk to the family, what is the care because ultimately when they go back, the family should be identifying them as somebody requiring more care and not treat them as still a servant, still 8 months of pregnancy, let her go until 9 and then get admitted. So comprehensive risk assessment and talking to the family helps at this stage. Many of the times we see that even in the joint families, a pregnant lady comes with neighbor, then we always tell them, bring your mother-in-law or somebody, we want to talk to them. Because if they don't have trust with the daughter-in-law, they would think that they're just fussing around. Specialized care and monitoring is important, especially in high-risk pregnancies, and that may include ultrasound, fetal monitoring, and then comes the delivery. During the delivery, if a lady has not undergone antenatal care in some of the private hospitals, they don't even encourage them to get admitted. In my own case, I'd taken antenatal care in one hospital. I'm a doctor. My husband is a doctor. But in that hospital, we found last moment, they were giving me injection compost to sleep so that they would deliver me next day. And I was very afraid of that. What if fetus has a distress? Who's around? Who will do emergency Caesar? So when I started asking questions, they said, you go. You can take against medical advice, you can take your discharge and go. Now here I was, a doctor. He had followed up for antenatal care, but I was left out of the hospital support system because I was asking too many questions. Then I came out. Then in Belgaum, where I was, this happened in Belgaum, nobody admitted me. There were 3 different hospitals that they refused admission to me because I didn't see the antenatal care with them. And then I had to take a taxi with my husband, my father, mother, and go to a neighboring hospital 150 kilometers where my father had made a blueprint for a dam when the hospital was built there, and the director knew my father. 150 kilometers in labor pain. There was floods. Literally, my husband had to get up and push the car. No, we couldn't go anymore. So 3 times we had to change route. I just went into the hospital and I delivered. If that happens to a person like me, who is a doctor, can you imagine what is the plight of a person in a rural area who has not undergone an antenatal checkup? I'm not saying every doctor is like that, but if this happens and if it's a standard practice in a place, you can jolly well imagine things are not welcome. They're not humanitarian many a times. So we should be very careful. And also the delivery, vaginal, cesarean. Many times people would like a vaginal delivery, hospitals force a cesarean section, and sometimes vice versa. So this is a vaginal or cesarean section deliveries. What is important is cesarean section should be done when there is an indication. I'm not saying always emergency cesarean section, because in some you don't want the emergency to develop. But if there has been a normal delivery before, if there is a chance of a normal delivery, there's no need to rush into cesarean because doctor is going out of station or patient's husband is flying somewhere, and these indications are not right. And then managing the pain optimally. And then the assessment, maternal and the assessment soon after delivery, uterine tone, the vital signs, postpartum bleeding, they're all important. And I'm of a great belief that the hospital delivery is better supportive than at home. Because you have somebody who comes around to check whether you're passing clots, whether you're bleeding profusely, whether it requires you to take back to OT or under anesthesia, get all the clots out. So this, I do not for one believe that all deliveries can be at home. It's possible if a lady has delivered 4 or 5 times normally, 6-1 or whatever, one could go at home, but it doesn't mean by nature, because many people still ask me this question. So what, in olden days, people used to deliver at home. But in olden days, there are 12 children, 10 children, 8 children. They would okay have to have a fetal wastage. But today, when we have fewer children, we do not want a fetal wastage. So neonatal assessment will be done. Breastfeeding and initiation starts immediately. But as much as I'm of a hard believer in hospitals, my daughter doesn't believe, because she delivered in Germany and she made it a point to say that she wanted to be delivered by nurses. And she didn't want a hospital intervention. She said, only if the nurses call on the doctors, then I'll give you in writing, I have my consent, I can be taken for cesarean. So she delivered underwater, and then she found it very nice. But I'm just telling you, the care in India, I would be very pessimistic about trusting the firstborn not in the hospital care. So, because there are so many initiating into breastfeeding, and this is an important practice, there is a consistent support required for the primary, first time when she's delivered. And breastfeeding, first time if you get it right, and subsequently you may not even require anybody's help. But there are mothers who have undergone cesarean, they don't breastfeed the child. Oh, it's paining. No, that need not be. This is where one has to be firm. Similarly, you have to make sure the cares are taken well. So now we come to what are the other support system: healthcare, peer support, access to mental health services. This is very important. All the more in India, where supposing a lady has delivered a girl, in the hospital practice where I was trained, if it was a girl, we wouldn't be rushing to say girl. We would say, okay, they have taken the child, they're making it cry, they're giving the care. We waited till the placenta was out. Because many a times, declaring prematurely, we have lost a patient who went into shock. And once she goes into shock, uterus cannot contract. The bleeding cannot stop. So it can be complications. So that is why we should also be open for postpartum depression, where a mother who's delivered series of girl children is afraid even to go back to her husband because she may be kicked out. So screening, and that is important. So comprehensive postpartum care is multidisciplinary approach, and this is happening in lot of hospitals, even the government setups, where there is a good care with a comprehensive interdisciplinary care. And then that is the time where contraception is offered if a lady is getting discharged, whether barrier method or hormonal methods, long-acting method. Sometimes I do feel bad because the moment you put a copper T or any contraception, when the uterus is not fully contracted, it has a chance of ejecting the contraception. But the government is so very strong on this issue that we want more numbers in contraception. We have targets. We have to fulfill the targets. The pressure was on us as a postpartum medical officer that how many targets did you do? If there are 100 ladies who delivered in the hospital, then at least we should make sure we have 60 copper Ts. I mean, this kind of targeting makes objectivization of human persons. So that is why contraceptive counseling should be individualized. It should also as much hearing as much as we talk. It is not one-way traffic that we go on talking, but we need to understand their own social, cultural, economic milieu in which we are advising something. And follow-up and support are also important. So it's access to counseling, the contraception, as well as encouragement for open communication and a shared decision making. Even with a hemoglobin of 5 or 6, when a lady has delivered 4th or 5th child, the men do not come forward for contraception. There was a time when I was an intern and I had advised this, that the husband can alternately go for contraception. He looked at me and said, "Are you married?" I said, "No." "Then you dare not talk about it. Talk this to your husband and he will slap you," he told me. I mean, that is, I'm not talking about individual case, but also reflects the culture which is patriarchal in our society. For one tubectomy, I have seen she had 7 children and she was all willing to undergo tubectomy because she had a heart condition as well. There were 7 members of her family who came to fight that why are you asking her for tubectomy? That because the brother-in-law of this lady did not have a child, so they wanted some children from her. So we just need to understand that above and beyond our advice, a lady goes back to her own cultural milieu. She has to live with them. So we can't be harsh in pronouncing our decisions. If you don't want to go, then don't come back at all. Don't show your face. This is not how we should be treating. So responsibilities, especially diagnosis management of pregnancy, prenatal screening, and also wherever required, the procedures that are there. Now the role of midwives, providing holistic woman-centered care throughout the pregnancy, childbirth, postpartum, and in many of the villages, ANMs, DIEs are also authorized to do this. In fact, I attended a conference in Oxford. It was called a Partu. A Partu is parturition birth, and it was only by the midwives. And they usually say that they are capable of doing a normal delivery. They would be, if the at least once the doctor has seen and cleared that they don't have a disproportion with the pelvis and other things, if they have given an indication, they can move it, but not before a thorough examination and looking for what are the barriers for the normal delivery. I think a doctor should still be one who will decide whether it's possible that the emergency could develop. So then the role of nurses, a compassionate care should be there. But more important is a collaborative care approach. I think I'm sure Dr. Mavnan will take it from here because he's talking about the consent and that. So now what are the government schemes that are available? So maternal health programs in India, National Health Mission, because especially due to the disparities that are existing and to improve access, the NHM has come into play. So there are certain key components. One is Janani Suraksha Yojana, which provides financial incentives for institutional deliveries and promotes skilled birth attendance. And also Pradhan Mantri Surakshit Matritva Abhiyan. So according to this, the comprehensive antenatal care to pregnant women, including early detection and management of the high-risk cases in pregnancies, and maternal and child health wings, which are specially for the antenatal care, labor, delivery, and postpartum care. Now, these are available in government hospital. They're also available in many of the private hospitals because these days, the private hospitals have a tie-up with which all the government schemes are also run. reproductive, maternal and newborn child plus adolescent health. So that was specially introduced in 2013 with the aim to reduce maternal and child mortality and morbidity. And neonatal policy for women's empowerment. When we talk of women's empowerment, we do feel that this is an area which is not much paid attention to. If we look at it only from the time of obstetrics and childbirth, it may not serve well. If we want to put actually empowerment, it should be from womb to tomb. It should start right from the conception. So this focus on promoting gender equality, health and the empowerment, especially access to maternal health care. And the Maternity Benefit Act, which is specially paid maternity leave and access to prenatal and postnatal care. Now, this is mostly in the organized sectors. In unorganized sectors, even then, some of them which come under ESIS, employees, this thing, they're available. But I have met a lot of people in our own construction workers nearby. I keep asking them, do they get an access? They don't. So we do know that those who require the most may be deprived from this benefit. And national health policy of reducing maternal mortality through targeted interventions. Now, we also have a Poshan Abhiyan, through which it's a government flagship program to improve nutritional outcomes. A celebration of a Rashtriya Poshan Mah with a whole month where in the maternal and child welfare. So these are some of the issues that are there. And there is one scheme which is a direct benefit transfer of money, cash transfer into the account of the pregnant woman for the first child, that is, for nutritional needs and partially to compensate for wage loss. I've seen such a scheme. I wouldn't even be able to pronounce it. It's in Germany. When my daughter delivered, the time she delivers, 2 months from before that, they get $300 in their account. And as soon as the child is born, the child gets 500, mother continues to get 300 to employ others to look after the child. So they make sure that child does not suffer from malnutrition because of want, because that time my daughter had not taken up employment. If you are employed, then your insurance takes care of it. But if you're not, then the government fairly and squarely puts itself in the place where they give a health card to the child and even the appointments for vaccination and other things. And I think that is truly where we must be heading to. That means from the time the child is born, if you're giving that kind of care, and also the first 12 years, including schooling, there is no fees. That makes sure there is an education that's happening when the child comes of age. So these are some things that we look at a care in continuum than only at one time money in the account. Although I'm not saying it is not good, it would have been so helpful to many of the people, but that is for first child. If it's the second or third, the same thing doesn't come into picture in case of direct transfer. So providing birthing experience, especially through Suman, which is Surakshit Matritva Anushasan, and a labor room quality improvement initiative, Laksha. So this provides assured, dignified, respectful delivery. Now, labor room, especially with a lady who has had a prolonged labor, we have had such horrific stories where they are made to deliver under conditions of hitting them on the leg or thigh and just don't stop crying. I mean, stop crying and just push and things like that. It is not a dignified way of treating a lady who is about to deliver. So I think this would be nice where we look at them and look at the care that we need to give and not our own judgment as to what they should do. So it aims to provide dignified, respectful delivery. And and many services, including newborn in the public health facility, to end preventable maternal and newborn deaths. And this initiative has been built on the progressive schemes like Janani Shishu Surakshana Karyakram, that is JSSK, and Janani Suraksha Yojana, JSY. They are no doubt very good. So when we look at what happened to the challenges, the health is a state matter. And whereas there are certain schemes that are available, when it percolates down to state, whether the state is making sure that there is a supply of information, supply of money coming in, there's a disbursement. So in between, if there is a leakage, then it does not reach the outcome. It does not go into the trickle effect going to the beneficiary. To assure provision of healthcare, particularly, National Health Mission has been made considerable investments. So this is again some of the yojanas, Pradhan Mantri Surakshit Matritva Abhiyan and Laksha. Through these schemes, even the labor room OTs have been brought up in quality. and innovations in maternal health care. Now, what has happened? One of the innovation I would say which went totally southwards was ultrasonography when it come to healthcare. People did not even realize that it would result in so many thousands of female fetuses being aborted. It is like a genocide proportion, like a war against female fetuses. So whenever there's an innovation, we need to also have an idea of how does it play out in the long run. Is every innovation compulsory? Is it, do you call it a kind of technological imperative? If there is a technology, it must be in the hospital, it must be put into healthcare. So are we sometimes driving the needs when we really don't need that particular innovation? That's just a remark I'd like to say. So technological advancement and innovations have potential to revolutionize maternal and child care delivery. Examples, especially telemedicine, health applications for remote consultation, prenatal care, and postpartum support. But also in the health application, sometimes it's difficult to have a mobile applications in villages which don't even have a constant electricity. How do they charge their cell phones? So point of care diagnostics and wearable devices, good, but how do you make it workable in rural areas with the illiteracy? So task shifting and community-based intervention to expand access to skilled maternal neonatal care in the low resource settings, and integration of AI and machine learning algorithms and predictive analytics. The more it is said about it, the more it feels to me very heavy, because we don't have much things in place as to who takes the responsibility if AI goes wrong. We don't have responsibility. Who will take, we don't have clarity if the privacy is breached, if the data is sold to somebody. So that is why we are rushing towards a technology without understanding the implications 5 years from now, 10 years from now, like we have done with even the ultrasonography machines. So I think we need to have caution in that. And addressing socioeconomic disparities. Socioeconomic disparities contribute to unequal access to maternal healthcare services. The best of your innovations will not touch the rural poor if we don't have a concerted effort to make it reach them. And strategies for addressing this would be enhancing access to healthcare interventions, especially such as poverty, education, and gender inequality. I would think when we look at a girl child, unless you make sure she has got a schooling up to minimum degree, then we cannot even assure a socioeconomic status for her when she gets married. Because everybody cannot walk out of the marriage. Even a lot of injustice have to be suffered because they do not have economic independence. So it is somewhere we should look at giving economic independence to everyone. And to conclude, maternal health care is a cornerstone of public health with profound implications for the well-being of mothers, infants, families. It literally builds the nation if it is done correctly. Comprehensive care encompassing prenatal, intrapartum, postpartum care is essential for safe motherhood. It will reduce mortality and morbidity. Maternal health care is at this very critical juncture. We have a huge opportunity to do better, and addressing socioeconomic disparities is the only way. We have to follow the Sustainable Development Goals related to maternal and child health. So these are the references. Thank you so much.
Thank you so much, ma'am. We're truly grateful for your time and wisdom. Your insights not only expanded our knowledge, but also ignited a newfound appreciation for the complexities of maternal health care. And especially all the personal stories and anecdotes that you shared were particularly very eye-opening for all of us. So thank you so much, ma'am, for shedding light on such an important issue. The floor is now open for questions from the audience. You can raise your hands or type in the Q&A box. Meanwhile, I request our co-chairs, Professor Vibhuti ma'am and Dr. Panorama ma'am to give their remarks and comments on the session.
Professor Vina Vaswani, your first-hand experience in the rural, peri-urban, and moderately urban place is extremely important. And I think we are hearing more and more horror stories about obstetric violence, the verbal and physical violence. I think when I delivered my husband being committed to public health sector, he wanted me to deliver in a government hospital. And in response, I got so many stories of horror stories of how women are beaten, the dirty talks that happens, the gossip among the nurses, doctors, and medical social workers that these people are breeding like cats and rats. And at that time, you are all enjoying, and now you are screaming and all sorts of things. Do we need a law for maternal this thing, safety in the hospital structure, so far as the maternity concerns are there? No. Are there laws in other countries about dealing with the violence in maternity ward? Can we have such law in our country?
Yeah, madam, they're not with specific to maternity wards, but the violence of even raising your voice is a criminal offense. So, because I can tell you for time when a lady had a very difficult labor, she had 2 normal births. This is a third one because I worked in a charitable hospital where most of the deliveries took place at night, and we used to have a power cut in Nagpur, and we had to literally run with lanterns here and there, and they used to invariably deliver near the latrine because that is, they would like to bear down. You can't differentiate whether it is a stool urgency or you're going to deliver in multis. So in that case, when it happened, and then we tried to, she was totally dry at the mouth. She was asking for something to drink. And then I went to get some, her relative, they always wait with a thermos of tea, coffee. And then I was shouted at by the doctor. They said, keep quiet. Then they told her, first you deliver, then we'll give you coffee. And I was thinking, this is very bad because she is wanting something, her body is expecting it because she is so dehydrated. We need to look at that. And I understand it's not a hospital, it's a charitable hospital. It doesn't mean that we can trade off quality or a human dignity because it's a government hospital. The dignity of women should be restored. So for that matter, this, even if a complaint by a patient that I was shouted at is enough to start an inquiry and punishment, then there are other restitution practices in hospital, in especially in developed countries where they come to say, they mediate to say sorry, including the doctors made to say sorry. And there's a reparative process. Whereas we find sometimes all patient needs is to hear that he was not attended to, but we are so afraid to say sorry because we think the moment we say sorry, there will be a case against us. So that is how sometimes labor rooms are very gruesome experiences people have had.
Nikita Sharma has raised.
Professor Vaswani, I have a couple of questions. Actually, it was a very, very nice presentation. But since I come from the background of working in 184 high priority districts, and especially being one on the rack when we introduced 5x5 matrix RMNCHA within the Ministry of Health. So as you rightly said, I think that since these people, like we have the researchers and we have the students of this, I would suggest that they better refer to SRS latest for the maternal mortality rate, because we have already reached 100 when it comes to the MMR as per SRS. So even though we have to further come down to 70, but India is one of the country wherein we have almost come down 70% as compared to international when we are putting dent to the MMR. Coming back to the NFHS 5, when we talk about NFHS 5 as per the ANC care, having 4 ANCs, I think that as per NFHS 5, today we are having 58% of the 4 ANCs have been done as per NFHS 5. The first trimester ANC is almost 84%, which is again, we are improving on that front, but with the purpose of, having the good maternal care and overall, which you rightly said, like 5x5 matrix was majorly introduced for having the connecting link between all the components of reproductive, maternal, newborn, child, and adolescent health. And at that moment, we had put emphasis on adolescent health. And there were 5, it was very easy, and their matrix was supposed to be on the radar of all CMOs, all district collectors, and that is how the letters had gone to across 750 districts across India. And maternal health, we had the components like MCTS, how you can use so that the moment Asha was being paid, you gave us some wonderful examples of international, but in India also we had those kind of things wherein Asha was paid 2,000 rupees for a complete delivery if she would support. And the mothers, which you rightly said, Pradhan Mantri Matritva Vandana Yojana, You spoke about JSSK, which was introduced in 2005. 2005 JSY, Janani Suraksha Yojana, the main purpose was institutional deliveries. And in 5x5 metrics, we had like how to identify the high-risk pregnancies, how to have the line listing of those women so that the anemia, we can identify them, how to have the delivery points completely equipped with oxytocin, with HR monitoring and having the partograph in the place, and how to notify like HbA1c whether that is being provided to the child, and then only those kind of money was transferred to Asha if she would follow the HbA1c, home-based newborn care, once the mother was out, whether the mother, in case it was the normal delivery, minimum 48 hours, and in case it was C-section, 7 days. So these were some of the parameters which were set by Government of India, even though not universally you can say implemented across. But then in RMNCHA, we had introduced the development partners, we had introduced the district monitors who would be doing the supportive supervisions across this, wherein infant mortality and maternal mortality was at highest level. And saying so, it was very informative presentation, ma'am. Thank you so much for giving us this overview. Over to Chair, Professor Vibhuti Patel.
Thank you, Dr. Manorama. Very, very, very informative, because you've also been in the field, and I have been only with the contraception, whereas you've been in the larger spectrum, so you have more access to it. So thank you for bringing me up to update on that.
Thank you so much, ma'am. Now moving to the questions from the audience. I believe there's a question by Subhada ji. You can go ahead with your question.
Thank you. I'm Shubhada from Gadchiroli, Maharashtra, and I'm an activist. I'm working since 1984 here. मैं हिंदी में बोलूंगी आगे का। तो जो सवाल मैंने लिखा था कि PMVY का जो ये है योजना जो मिलनी चाहिए, वो अनमैरिड मदर्स को नहीं मिलती, क्योंकि उसके पोर्टल पे उन्होंने हस्बैंड का आईडी मांगा है, और वो मुश्किल होता है क्योंकि आदिवासी विभाग में बहुत सारी जो बॉयज एंड गर्ल्स वो शादी नहीं करते हैं, पर वो लिविंग रिलेशंस में होते हैं और बच्चे भी पैदा होते हैं। तो इसमें बहुत ही मुश्किल बात है कि सभी जो चीजें हैं जो हम बोलते हैं कि दीज आर द एंटाइटलमेंट्स, सो वो नहीं मिलती है। तो इस तरह का जो डिस्क्रिमिनेशन होता है, तो इसलिए हम क्या कर सके वही।
I think what you have asked is a very, very genuine question, because when it comes to theory, something sounds good. But when it comes to practical application of it, there is a gap. And this gap has to be done or repaired by people who are in the field, like me, like you, by making maybe a study on how many people were deprived or in real life, because this is actually a case scenario. It's like, even we have done the similar studies. When you know that when you deprive somebody from this, then how can you say that they're suraksha? There is no suraksha happening there at all. So maybe it requires us to look at a maybe nationwide study on a particular tribal population, or general, how many people require it but they don't get it because they insist on the husband. Because like Mala made a difference between reproductive and sexuality. This comes in the realm of sexuality, but it connects to reproduction. Whereas the government insists on reproduction is only within husband-wife. Whereas the sexuality land itself, where it is exposed to pregnancy and which is not taken care of. And I do believe, and I'm very serious concerns about when people make these rules, are there enough educated, seasoned, nuanced females with judgment who are sitting there? Or is it just on the go what they feel with the patriarchal behavior? So, I would like people like Dr. Manorama, Dr. Vibhuti, or activists like you to be a part of it. Yeah. Because you can then give a nuanced approach to it, how they should handle it. But it's a very good question. Maybe we should think of the challenges by this, when you make a father's name in the portal compulsory. It is like us, because we look at deaths, and in the we have a portal, but then they expect that you have to give the name of the deceased. But now I want to enter it to see if my relative is deceased because I don't know whether he was there or not. So how do I access it? So that's why there are certain questions which are not answered. So that is how this is one of them, but this requires urgent attention as well. So maybe
Yeah,
a
so it is,
study would help.
I would like to say that it's gone beyond study because Shubhadaji is a part of Ami Amcha Arogya Sati. It's a big flagship program of Government of Maharashtra under NRHM, National Rural Health Mission. Enough evidences are there. Now it's a question of GR. When it happened with the LIC officer, when she asked for maternity leave and she was not married, she got termination order. And immediately we brought it up. And it was raised in the Parliament of India that maternity and morality are two different issues. So it should not be brought in. And now in the organized sector, at least nobody asked a woman whether you are taking maternity leave because you have adopted a child, or you are married and delivering baby, or you are unmarried and delivering. Nobody asked women in the unorganized sector. Why can't it be applied to tribal women? Why can't it be applied to poor women? We need to have the same yardstick, no, for this thing. So it is at that level. So I think now it is a time to make a policy intervention that this should be irrelevant whether she is legally married, and why should you ask for husband's Aadhaar card? No, her own Aadhaar card is enough to identify. No, yeah.
And sometimes
Madam,
I find it unjust. Sorry, I just find it
No, no.
unjust because there are certain schemes, like if a person is dead and he doesn't have anybody, then on 10,000 rupees is given for his cremation or whatever. So the person is shown dead 5 times and money is collected. Where it is not at all required to be done, they have enough things to say, okay, once he is done, you cannot subsequently do it. Whereas that is too much excess of it collected, and here a glaring gap where nothing goes to the person who is deserving. So why is it morality a huge concern with people, whereas making excess drawdowns is not a concern at all?
Yeah.
Well, coming here with a small submission, ma'am. Actually, the Pradhan Mantri Matruttva Vandana Yojana is the only scheme for the pregnant mothers from Ministry of Women and Child, and not from Government of Ministry of Health. So I think that since it is from Women and Child, the more pertinent it is for to be addressed like at that level. And in that, they have purposely kept that the second child is to be, in case the second child is a girl child, she will be provided with those 6,000 rupees. Otherwise, like only the first child.
Yeah.
So that is to enhance and to sort of like so that the girl child is sort of, yeah.
Nikita ji, there is one more question. Lakshmi Chetri. Lakshmi ji, can you unmute and speak?
Yes, thank you, Vina ma'am. It was
Introduce yourself.
really informative. I am Lakshmi. I work with an organization in which is based out of Assam. I could relate with your the anecdotes which you have shared. We see here a lot of in the government hospitals what are the situation is like, and especially with the doctors, and most of the time, especially during COVID also, we have witnessed that there was no doctor, and then women had to travel long for and so many unwanted pregnancy cases we have seen. So my like just the concern is, how do we held accountable the especially the healthcare provider? One is, you also mentioned that in the comprehensive cares, the someone has to counsel the women about her diet, nutrition, exercise. I have like, I don't remember if any women have had uh, you know gone for counseling or was asked to attend any counseling session, or even if she has attended, I have never heard or never seen any women who have been asked, or given some sort of advice on her diet or exercise, or yeah. So Can you enlighten me on that? That how do we make them more accountable?
Actually, a lot depends on the treating physician, obstetric gynecologist, because some of them are very sensitive. And if they find that the lady is showing signs of depression, because I bring now some experience from the medical institution, there's always an interdisciplinary team. So the cross referral is possible. They are treated because one of my cousin, some relative had delivered 3 female children, and her husband had said, only if you get male child, I will take you to Germany. So that's one of the reasons she went into severe depression. But then we were told the very next day that the psychiatrist was there, the counseling happened and thing. But I'm not sure about length and breadth of it all over what is the scene. So Dr. Manorama can say something about this.
Well, madam, it has even I have myself seen it in supportive supervision. I'm just sharing with you the case of Panipat only, which is very nearer to this place, wherein I went and I checked couple of females whom they said that she has been given the IUCD, PPI IUCD. So I inquired from her, आपको क्या, because normally you have to take the consent as per the government of India. You have to take the consent form, fill the consent form. Yes, I am in for PPI IUCD. I checked with almost 5-6 females and I told them कि आपने ये जो सुई लगाते हैं, they call it सुई, ये जो आपको लगाई है, आपको पूछा गया था? उसने कहा कौन सी, मुझे तो पता ही नहीं, मुझे क्या लगा. And that was the kind of like counseling. Otherwise, it's imperative to counsel a female whether she wants it or she doesn't want. Number second, then this prompted me to check कि कितना PPI IUCD and IUCD hospital में था. I checked the stock register. They had shown that they have done 60 PPI IUCD, while a stock register had only 30 PPI IUCD. Then I called the person and I told him, how is it, sir? When stock is showing 30 and you are showing that 60 have been already done to women. So those kind of things are there, even though the laws and norms and everything is there on, but implementation is a big challenge, and monitoring and supervision needs to be done in a proper way. It has to be more supportive, getting everybody, state bodies and people around, like hospital authorities and community mobilizers along, so that they don't see it as a threat. It has to be very supportive, maybe probably like we can see these things happening. I completely agree with what Subhadra ji said and what Chetri ji said from Assam, because these are the experiences from the ground, and we have witnessed it. I have been to Gadchiroli, I have been to Anand Bang ji, वहाँ पे जो भी उनका काम चल रहा है वो मैंने देखा, home based newborn care देखा है, and we have witnessed it ourselves. Even though like programs are there, guidelines are there, but actual implementation is challenge.
Thank you so much, ma'am. Looking at the time constraints, we'll be concluding this session now. So first of all, I would really like to thank ma'am for her valuable time. And thank you, ma'am, for sharing your passion, expertise, and wisdom with all of us. It has truly been a privilege to have you as a part of our event and to learn so much from you. Thank you so much.
you.
Really anticipate the opportunity to collaborate with you again in the future.
It's always a pleasure because it's a two-way learning experience, because nobody is complete till they have the experiences of others, and that brings into our own learnings. And so next time I speak about it, I can even get in the experiences shared by you all. So I've never just been teaching without being a learner. So thank you so much for the opportunity. I take your permission to leave because I need to be going. Otherwise, it would interest me immensely to stand and listen to throughout, but I have some difficulties, so I'll need to leave.
Yes, ma'am, for sure. Thank you so much, ma'am. Now, I'm delighted to call upon Dr. Padmaja Samant-Mavani ji for her keynote address on the topic Understanding Sexual Health, Navigating Consent, Legalities, and Women's Challenges. We welcome you, ma'am. If you could please take it from here.
Thank you so much. Shall I share my screen?
Yes, ma'am.
Yeah. Is it seen?
Yes.
It's in working mode. Now fine.
Yeah. So, first of all, I am, all the discussion, I'm a gynecologist myself, and the discussion over last 2 sessions was sort of an eye opener, and secondly, sort of sense of accountability, which is challenged. That the denial of services, abortion services on one part when Mala spoke, and secondly, the way there are lapses in maternity care. So both the things actually are very vital to make a woman's life productive, meaningful, and secure, so that she is very important stakeholder in the nation building and society building. Now, what we are going to do is we are going to step back slightly. I'm going to come out of the reproductive health part, and we are going to look at understanding sexual health, navigating consent, legalities, and women's challenges. So here we have various different women, girls and women from different realms of society. We have Fool and Jaya on one side, where they are these young brides who are looking at their husbands to give them accompaniment and support in their new houses. There is Bella Baxter of Poor Things, who is actually an infantile brain transplanted into an adult body, and she makes her own mistakes and she learns from her mistakes. And then there are Meenal, Falak, and Andrea from Pink, who are hauled over the coals by the defense lawyer just for standing up to molesters and taking their case higher up. So do all these women from different realms of society, do they have sexual autonomy? Do they know what are their sexual rights? Can they exercise their sexual rights? What is sexual health for them? Where does sexual health discourse start? Should it start at an age where they are after 18, or it should be starting in adolescence, or it should be starting much earlier with parents, where parents will be able to actually guide their children through safe sexuality, mutual respect, and making friendships more meaningful. So the objectives of this session are: one, understanding of definition of sexual health, sexual autonomy, consent in the context of sexual autonomy, masculinities, patriarchy, and effect on sexual autonomy and health, violation of people's rights at various levels, legalities being challenged for beneficiaries and healthcare providers, and maybe some solutions. So sexual health. The WHO definition is a state of physical, emotional, mental, and social well-being in relation to sexuality, and not merely the absence of disease, dysfunction, or infirmity. And the health requires a positive and respectful approach to sexuality and sexual relationships, as well as the possibility of having pleasurable and safe sexual experiences, free of coercion, discrimination, and violence. Now, this pleasurable and safe sexual experiences, free of coercion, discrimination, and violence, is the most important part of the sexual experiences and sexual health. So, our Bella, our Meenal, our Andrea, our Jaya, and Fool, all of them require to have supportive and responsive partners. Bella requires to have a supportive Alfie. Jaya and Fool require to have not the dowry greedy Pradeep, but a supportive Deepak. And most importantly, the modern young women of New Delhi, where the whole scenario of Pink plays out, they require to have a supportive judiciary, a conscientious lawyer, and supportive society. All this only will make it possible for sexual health of a person where they will feel safe and the sex will be pleasurable for them. Now, coming to what is sexual autonomy. So broadly, sexual autonomy is a human right to protect and maintain an informed decision over one's own body, one's sexuality, and one's sexual experience. It allows women to navigate sexual experiences. This is very important, setting boundaries. So a woman should be able to set boundaries of what is right, what is wrong, what is pleasurable, what is not pleasurable, what is safe, what is unsafe for herself. She should be able to recognize their sexual feeling as distinct from societal pressures and desires. And she should be able to exercise control in her own sexual decision making. Is this too far and too much to expect from society for a young woman of today? Maybe even for a young man. Why should I be talking only of women? Because it has to be mutual. And by the way, I constantly keep, just as any of us, we generally look only at men and women. I am still talking of sexual binaries, but sexual health is not only for the binaries. It is for all gender diversities. It is for all the groups. And we should come out of this sexual and reproductive health together, and we should dissociate them and look at sexual health for all gender groups and sexual and reproductive health for men, women, for lesbians, and for gays who want to have families together. Going ahead, we will look at some physiological studies. How do they differentiate men's sexuality from women's sexuality? Let us look at them. So there is a physiology study from, it was in about 18 and 18 men and women, where sexual arousal was linked to the neural activation of broader range of brain regions in women compared to men. Now, what was done in the study was that these people were actually, the temperatures in the genitalia were measured. They were made to watch erotic films, and MRIs of their brains were done. And what was found was the temperature changes in the men's genitalia were associated with activity in the certain areas of brain: supramarginal gyri, frontal pole, lateral occipital cortex, middle frontal gyri. And what surprisingly in women were found was it was associated, in addition to these centers, with many other centers which were actually dealing with emotions, warmth, pleasure, emotions which were a little more higher than only the physical pleasures. So in inference, what the authors have said is that what's going on in the brain for women during sexual arousal is really important for the physiological responses and vice versa. So actually, woman seeks more from sex and more from sexual pleasure than what she is given credit for. It's not only the orgasm that she seeks. It's not only completion of the sexual act that she sees. And definitely she is not a passive partner in sex, where we always tend to believe that men have sex and women reproduce. Woman is an active partner. She wants to have an active role. And she should have the autonomy to say, I do not like this, or I like this, or I am in for it, or I am not in for it. Now, this is another study which talks about nonlinear model of female sexual responses. So what it says again is that this is study by Rosemary Basson, and it says that female functioning is affected by numerous psychosexual issues such as satisfaction with a relationship, self-image, and previous negative sexual experiences. Very important, previous negative sexual experiences. If we look at how many children or adolescents have been having some or other sexual experience or sexual abuse experience, negative sexual abuse experience, 3 out of 5 female children and 2 out of 5 male children have had some sort of sexual abuse as a child. This is world over statistics. So if these women have negative sexual experiences in the past, what their functioning will be affected by is also by these experiences. And the Basso model clarifies that the goal of sexual activity for women is not necessarily orgasm, but additionally personal satisfaction, intimacy, and connection with the partner. Very important, where the partners also should understand this, and the woman herself should be able to assert on this. Now, for want of, because we are so much late, I will just skip this, but this is an important study, a Dutch study, which has talked about how young people, what sort of agency they have and what sort of restrictive factors, barriers, or facilitating factors they have as far as their sexual agency is concerned. So it was divided by this Marianne Sense into 4 different, it's a choice model or multi-component model that she has proposed, where she says that it is the embodiment, there's a physical experiences, it is the bonded experience, that is the cultural restrictions or religious restrictions that the children feel, moral restrictions, because there is a deep sense of right and wrong among children and young adults. So all these are the different multi-component models which actually decide how people take agency of their own sexuality, how they own up their sexuality, and how they manifest their sexuality. This is a sexual health counselor. Her name is Emily Nagoski, and what she has talked about is the truth about unwanted arousal. Seemingly, it's a very strange title, but a very important part that Emily has stated is that if a person is feeling aroused, that is, if the genitalia are wet, throbbing, warm, etc., etc., not necessarily it is out of cortical sense of pleasure. It is out of cerebral sense of pleasure. It may happen at various different levels physiologically, and the woman still has to say, this is not the arousal I wanted. And why she actually makes more sense is because there are defense arguments when a child is raped and the rapist says, oh, the child was asking for it, she was all ready for it, so she had consented. So it doesn't mean just because somebody shows physiological response that she has consented. So now here we have made a distinction between male sexual experiences and female sexual experiences, and why female sexual experiences are quite different from those of males. How do contraceptives play out in sexual experiences? More women than men have complained about physical displeasures of male condoms, according to this study, which has been in the American Journal of Public Health, because condoms take away the sensations. Men haven't complained, but women have complained. Also, women were also more likely to experience contraceptive side effects because most methods actually are targeted at them. Women also have problems with oral contraceptives and progesterone-only contraceptives, also from other forms of progesterone contraceptives like injections and like your implants, etc., etc., because they all take away the amount of secretion that should be there at the time of sexual act. They make the vagina feel dry. They take away the freedom of sexual experiences because the woman can have intermittent spotting, intermittent bleeding, and dry vaginas. Now, when all this happens, actually contraceptive doesn't really contribute to the sexual freedom or sexual pleasure. This much about physiology. Now let us come to consents. These have been, the Khannas and the Khans have been our most adored and lapped up characters in movies. So what does consent mean? we look at consent from the point of view of patriarchy and masculinity. Patriarchy is a system of relationships, beliefs, which is embedded in political, social, and economic systems, and a strong structure of gender inequality between men and women. It can be protective patriarchy, or it can be toxic or imposing patriarchy. Masculinity involves displaying attitudes that signify and validate maleness, and involves being male recognized in a particular way by other men and women. And masculinities and patriarchy dictate how behavior of women has to be construed or understood when they say no. Uski na mein hi haan hai is a standard teaching by all the Bollywood movies which we have watched over a period of, I don't know how many decades. Aradhana was there when I was a child. So last 50 years ago, and Dar was there about 15 years ago, and today's movies also. So all these movies tell us the same thing. Uski naam hai haan hai. So what is consent? That problem of consent and problem of female sexuality, suppression, are ubiquitous, and they are across the decades, across the social strata, across the economic strata. This is another study which actually says that the various factors that cause suppression of female sexuality actually can be divided into masculinities and patriarchy and gender inequality. So it's not only males who suppress females, or females who suppress males, or females who suppress males, but the societal structure as such, the wider structure that causes gender inequality and patriarchy, which is responsible for suppression of female sexuality. Coming to domestic violence. Now, when power over woman is concerned, various ways in which violence can be used. There can be economic violence, there can be emotional violence, there can be coercive sex, there can be bargaining with children, custody of children, there can be emotional blackmail, numerous ways in which a woman can be made to submit to violent sex, one, and domestic violence can be perpetrated against us, not only as a sexual violence, but as a power inequality or power differential. So various ways in which woman is made to feel subservient, is made to be a slave to the family, and she can be manipulated in any which way by using all these methods. So the consent. Now this consent, what has been normalized by our mainstream media, what has it done? The number of cases of acid throwing, the number of cases of stabbing, which are occurring in daylight in large metros, which are horrendous. How can somebody just because somebody has said no, let me deface her, let me throw acid at her, let me intimidate her in the way, let me stab her. This is what has actually our media taught us. So this is how we have understood consent. And this is what has to be taught to young children at the age of 15, 16, because at the age of 15, 16 is where the boys' negative sexual experiences, boys is causing rapes to younger girls, etc., all starts happening. And then these become into the otherwise social monsters. This is another TED Talk which I came across, which is by Maria Allen, and that was about pornography. So she's also a sexuality counselor, and she talks about let's stop porn. And she has highlighted how pornography has created a very warped sense of human sexuality in the watchers' minds. Actually, with technological advances, younger and younger children have been having access to internet, have been having their own mobiles. And when all this happens, what they watch when they are sort of encouraged by their peers. And when they learn about, children generally learn about their sexuality, not from parents, not from teachers, but from peers and also from media. So when they learn about it and they watch porn and they become addicted to that, they can get addicted to substances, they can get addicted to violent sex, and they can perpetuate that same thing on their partners. It may be slightly less powerful boy or a girl. It can be anybody. But anyway, losers are both boys and girls. And this can happen as an addiction. It can go on to ruin their lives in longer run. So teaching porn literacy actually, none of us know how, if I consider myself how to talk to a child about what is pornography and what is porn literacy. I am at sea. I wouldn't know how to talk to a child about this. Psychologists have to talk, but what about the safety and sexuality of it? Is it only psychologists who should be talking? Let's see what actually National Medical Commission says. Let us come to that. So psychologists are working to correct human sexuality misconceptions perpetuated by use of smartphones, looking at pornography. Now, challenges. When so many women have their own challenges, how can we divide these challenges? Let us see. First and foremost is the masculinity and patriarchy which is there in society, right from womb to tomb. Violation of rights at various levels and legalities. Let us see one by one. Health systems. It's very awkward and very, I feel almost guilty to say this, but there is lack of training about addressing sexual health. We address only reproductive health. And sexual health, if we have to talk, we talk in terms of sexually transmitted infections rather than about healthy sexuality. We don't know what healthy sexuality, how it is to be communicated to and to whom, at what stage we should be talking about it. Then focus is on reproductive health, STIs and RTIs. Lack of culture of addressing sexual issues of couples. Gynecologists will talk only to women, and maybe psychiatrists or dermatologists, because they are venerologists, they will talk to men. I do not know why this such segmental or fractured counseling is there, but that is how it works out. Patriarchal belief system also in us. We are equally patriarchal as the judiciary is, as the police are, and we are not at all empathetic to the young girls and young women who come to us. There is no acknowledgement of other than two genders. Definitely, it is not taught in any of the, we will see the NMC competencies actually. Then discomfort in addressing gender and sexual diversity. So now let us look at what the NMC teaches, or rather expects us to teach. This is Forensic Medicine 3.14. This is the thing on sexual offenses that we require to teach. And it says sexual offenses, describe and discuss the examination of victim of an alleged case of case of rape, preparation of report, framing the opinion, preservation and dispatch of trace evidences in such cases. Does it talk anywhere about taking consent of the young girl or the lady or the boy, whoever has come to us as a sexual victim? No. So it doesn't really talk about it. It actually talks about the patient who has come and the organ system which I'm supposed to examine, and I'm supposed to prepare the report. This is how it seems like. Now, this is all sexual and gender identity disorders, all falls under psychiatry. PS is psychiatry, 13.1, 13.2, 3, 4, 5, 6, 7. And everywhere it talks about psychosexual and gender identity disorders. Now, what does it mean? Let us see. Gender identity disorders. Nowhere is lesbianism there. Nowhere is sexual diversity is there when we do the search of the PDF files of these CISP modules. So they are here. They are called as gender identity disorders. Very sad, but we do not acknowledge them as a normal phenomenon. We acknowledge them as identity disorders. And what we teach is how to correct these and how to correct them pharmacologically and psychosocial therapy, etc., etc. Coming to sexual offenses, 3.16. Describe and discuss adultery and unnatural sexual offenses, sodomy, incest, lesbianism. So what it does is that lesbianism and homosexuality and other gender identities are all considered as sexual offenses. Now, what are we teaching? This is for the exiting medical graduate. These competencies are supposed to be there. If these are the things that the exiting medical graduate is taught and sent out, and the medical graduate is supposed to give basic care to the society, what sort of basic care they are going to give as far as sexual health is concerned, it is quite startling. Now, single person's rights as far as childbearing is concerned. Our participant from Gadchiroli, Mrs. Shubhada, I think she had spoken about the single person's rights to have children and as government beneficiaries. But in my hospital, which is a major hospital in a metro, if the understanding of a nurse is that if the live-in partner of the person comes and says, I am her live-in partner, you can hand over the child to me. I am the one who had registered her when she came for admission. What the nurse tells him is that show me your live-in certificate. Like as though there is a marriage certificate, there is a live-in certificate. This is the understanding of the healthcare team. If this is there, and then we have to do firefighting exercises and damage control exercises, it becomes extremely difficult. But this is how the limited understanding of individual rights is concerned is there. Coming to legal systems, the delay and the waiting list of various different cases of sexual offenses which are there, very high number, over 2.43 lakhs POCSO cases pending in the last fast track courts till January 23, and 3% conviction rate in 2022. This is the report from legal researchers. We all know about the plight of the proposal of marital rape as to be taken out as an exception. So this is a May 24 report, which has talked about Justice Aluwalia from MP, who has said unnatural sex with wife is not a rape because consent is immaterial. So actually only two exceptions to sexual offense as rape are when the wife is under the age of 18, and second is sexual intercourse by a husband upon his wife during the period of separation of minimum 6 months. So there is no hope for so many women who are daily undergoing rape in the system of marriage. If they object, and you should see how people and society, when people talk about these on the internet, what sort of reactions come from the society, reactions from men, reactions from women, reactions from everybody, that women are trying to sort of blackmail the partners by alleging rape. Nobody is willing to understand when woman alleges something like this, she is putting her life at stake. She is putting her children's security at risk. She is actually risking being called unfaithful, being called not a model wife. All that she risks because she is going through so much. And then here we are victim blaming. Now, there are certain changes in the Act, Criminal Amendment Act, which actually have not translated into us as doctors actually emphasizing certain things, and judicial, like the defense lawyers, not making the matters easy for women. Now, when the question of consent is an issue, evidence about the character of victim or of such person's previous sexual experiences with any person shall be not be relevant on the issue of such consent. So when it is said that the previous sexual experience or the character should not be relevant to that particular case, but still, time and again, defense lawyer will ask the expert witness about whether the history has been written down or not. And doctor, what is your opinion about her previous abortion, or what is your opinion about the status of her hymen, and so on and so forth? Why does she not have injuries? And then we are not adequately trained to even answer these questions. That there are numerous reasons. Actually, the document, a beautiful document by Ministry of Health and Family Welfare is there, which we ignore to read. The document says every explanation which can be given is there, given in the document. My friend Dr. Jagdish Narayan Reddy has, and colleagues from Sehat have done a wonderful job, and still doctors have not been able to use these things. It shall not be permissible to adduce evidence or put out questions in cross-examination of the victim about her general immoral character or previous sexual experiences, but this also perpetuates and creates a hostile environment and an awkward situation for the girl in question. This is the document which I was talking about, and this is a fantastic document which is already in public domain. And what it says is the reasoning for absence of injuries must be mentioned while writing the opinion. But nobody does that. This also says copy of the entire medical report should be given to the survivor free of cost and immediately. But nobody does that because, one, because we are not certain whether we have done a right job. We still require to do something about it. We still require to think about it, and we have lost all opportunities and we have not done the necessary reading. Coming to the end, what could be solutions? One, we really have to overhaul our teaching in medical schools. Teaching in medical schools and texts for doctors to talk about sexuality and sexual problems with individuals and couples. Teaching in secondary schools about healthy sexuality, safety, and respect. And discussion skills for parents about opening discussions with their wards. And sensitizing judiciary about what women want. This is what I understand might start making a significant dent into the question of sexual health, and we will at least have started the discourse. So here we are, we require to talk at this age of 11, 12, 13, 14, about what healthy sexuality is. And this should not only be left to the Anganwadi workers, and there should be a strong force of doctors, nurses, and anybody who can to talk to these young people of today and citizens of tomorrow. So thank you all very much.
Thank you so much, ma'am, for such a comprehensive presentation. You really imparted a lot of knowledge to us in terms of the legal foundation that lays behind everything that we spoke about today. So thank you so much, ma'am, for your wisdom and your time. The floor is now open for questions from the audience. Meanwhile, I request our co-chairs, Vibhuti ma'am and Manorama ma'am, to go ahead with your comments and suggestions.
Thank you, Dr. Padmaja Samant-Mavani, for a mind-blowing presentation. I once again say it was mind-blowing. I learned my lessons of hand-holding of the survivor of violence from you and your colleague way back in 1978 in my student days, where you all supported Aruna Shanbag, where everybody was talking about she being a Chatak Chandani and over smart and she deserved it, and all sorts of dirty things one had heard about this nursing student who was brutally raped and or was chained to such an extent she became a vegetative state. So one realized how difficult it is for hand holding, no? So this whole journey, which one has learned, I was new to Mumbai city and just getting involved in the feminist activism. But I think this is I have a very, very strong and fond memory of your colleagues, and you were the first one to even start the gender in medical education. So I think one has learned a lot from you. I would publicly acknowledge that. But at the same time, you also tell us it's not only the awareness generation, but structures and systems, how do we create so that the whole ideology of victim blaming gets converted into hand-holding of a survivor so that she can rebuild her life. And we have seen wherever the women's movement has stood by a survivor of even gang rape, they have rebuilt their life. No? So thank you very much.
Thank you, Dr. Padmaja. Thank you so much.
Thanks.
Thank you so much, ma'am. Are there any other questions from the audience? I believe there's a question by Arhita ji. You can go ahead with your question.
Hello, ma'am. I hope I'm audible.
Yes, yes.
So I'm Arhita, PhD scholar in sociology, Presidency University. So when you were talking about the physiological changes or activations in different areas of the brain in men and women during sexual arousal, I started to wonder what happens in trans men and trans women. Does identifying as a gender other than the one assigned at birth alter these changes by any chance?
No, what happens is in the trans men and trans women, if they have undergone surgery, we must understand that surgery always doesn't restore tissues to its normalcy. You know, like if somebody creates a vagina in a trans woman, it necessarily does not mean that this physiological functioning of that epithelium is as expected as that in a otherwise cis woman. So that is one thing that has to be understood. They would be given hormones which would actually replace the and make changes to the tissues, but it really does not equalize the experiences to those of cis people. At the same time, it is to be understood that sex is beyond genitals. Sex is in the brain too. So when we talk about this, what they have lost on genital experiences, they are still able to make up in the form of intimacy and emotional satisfaction and gratification.
What about menstruation and pregnancy?
Menstruation and pregnancy, pregnancy is, most of them would be having a surrogate child rather than their own child. But menstruation is uterine transplant, etc., is far-reaching. We are still not in that realm because, again, somebody has to have a matching donor for uterine transplantation. A vagina may be created, but menstrual function may not be there, and reproductive function also may not be there.
No, but during the pandemic, so many cis transgender persons, they asked for menstrual pad and they were denied. So even for the social workers, it was this thing. Then first
Yes,
time
yes.
we learned that they
Yes.
also need menstrual
I understand. What I am saying is that if somebody has changed the gender, I'm talking of that person's what you call menstrual and reproductive function.
Okay.
Thank you so much, ma'am. Are there any other questions from the audience?
Yeah. Anonymous attendee, you will have to identify yourself and then ask the question. Your question is there in the question box. Yeah. Hello?
Yes, ma'am.
You can read it.
Yes, ma'am. I'll just read out the question. So the question is, thank you for your valuable knowledge and insight sharing, ma'am. I would like to know about the status of single men who don't wish to get married but would like to have their own biological child. by using ovum and become a parent via means of surrogacy? Are they allowed to by legal means? And what options do they have other than adoption of a child to become a father without getting married? Thanks.
Yeah. So surrogacy is an option for them. The thing is that it's a little more complex with the surrogacy coming under a very strict law now. So we require to do a lot of sort of, ground work as far as that person's intent. They are called as intending parents. So the intending parents eligibility has to be studied, and then it is put forth to the government board which is there, and then they are allowed to do sperm donation and have a surrogate pregnancy. Adoption becomes a much more easier way out for these people rather than surrogate pregnancy, because the question of surrogacy is one, it is extremely sort of the issue of surrogate mother, etc., all these are there. The safety of surrogacy, surrogate mother is there. Adoption becomes much more straightforward and easier way out, but this is there. The option is there. It is put up to the board, and the board does the necessary groundwork.
Thank you so much, ma'am. Are there any other questions from the audience? Seeing none, we will now be concluding the session. So first of all, I would really like to thank ma'am for the way she has articulated such complex concepts and patiently addressed all our questions. Thank you so much, ma'am. You've truly expanded our knowledge on the subject and have inspired us to explore further depth. We really look forward to the privilege of having you as our guest again down the road. Thank you so much, ma'am.
Thank you very much. Thank you.
Thank you. I have a question for our co-chairs. If Professor Vibhuti ma'am and Dr. Manorama ma'am, if you allow, we can have a quick introduction of the participants right now. Okay, so I would urge the participants to turn on their cameras and turn on their mics. You can give a brief introduction about yourself, possibly talk about your designation, the organization you're working with, and what your motivation is to joining this course. First of all, I see Shubhada ji. You've turned on your camera. Thank you so much, ma'am. You can go ahead with your introduction.
Good evening. I'm Shubhada from AMI, Amcha Arogyasati, We for Our Health in Gadchiroli, Maharashtra. And I'm
Thank you.
a member of the organization. Thank you.
Thank you so much, ma'am. Now, Amithi ji, if you can go ahead. Okay, Arhita ji, would you be able to go ahead with your introduction?
Am I audible now?
Yeah.
Okay. I'm just turning on. Yeah, good evening, everyone. It was really nice to hear from you all. It was really a learning experience, and I have really learned a lot from all of you. The first-hand experiences and the knowledge which you have imparted from this platform is really commendable. And about me, myself, I am working as assistant professor in with the University of Rajasthan, Jaipur, in Department of Sociology. And the motive behind joining this particular course was I have recently started looking at this particular issue on SRH, one of my student was also looking at this particular issue and she has taken up as a PhD topic. So I wanted to know about more on this topic and wanted to understand what exactly happening across the other parts of country. So when I have seen the brochure and the panelists, so I really wanted to listen to them in person. So it actually on the first day it is really commendable. So I'm really happy that I have joined it. So thank you so much for me.
Thank you so much, Mithi ji. That was lovely. Ahita ji, you can go ahead.
Oh, I'm Orita. I'm currently pursuing my PhD in sociology from the Presidency University. I actually wanted to join this session because I'm also the co-founder of a very small NGO, Spriya Society, and we currently work on menstruation and menstrual health with school-going students. So I just wanted to develop my knowledge and learn a bit more.
Okay. That's great. Thank you so much. Uma ji, you can go ahead.
Yeah, good evening, everyone. I had an opportunity to listen to these wonderful lectures. I'm currently working as a professor in one of the College of University of Delhi. So I'm actually in the field of biomedical science. So and I have done a lot of research in STDs. So this is the basic reason why this particular field interested me. And I wanted to, slightly learn more about this field and get into it. And since I'm working with AIMS and Safdarjung Hospital in collecting samples, so I just wanted to increase my knowledge base. That was the main reason. Thank you so much. And the sessions were really good. Thank you.
Thank you so much, Uma ji. Dr. Varsha ji, you can go ahead.
Yeah, hello. Good evening, everyone. Myself, Dr. Varsha Gaikwad Anand. I'm an associate professor. I am from Ayurveda background and I have my specialization in gynec and obstetrics. So the basic reason for me to enroll for this course was to know a much more dwell deeper into the reproductive and sexual health of women, because as an Ayurvedic gynecologist, we get a lot of patients who come to us where they have already tried many allopathic treatments like IVF and all. So I wanted to know much in deeper about menstrual health and reproductive health, wherein I can help my patient as well as I'm associate professor, we have batch of 100 students. So what extra I can give to them? How can I replicate the knowledge which I am learning here for the benefit of my students as well as my patients?
That's really interesting. Thank you so much. Now, Chaitali ji, you can go ahead. Okay. Lakshmi ji, you can go ahead.
Hi, I don't know if you can see me, but because I'm not seeing myself, I'm a designer and I have worked in the area of reproductive health from a very, very long time. And I know Vibhuti Patel from then. So yeah, I was previously a MacArthur Fellow 20 years ago. And the reason I'm on my way to retire now, and the reason I've joined is just to update myself and to see, what's happening around me. So that's why I enrolled for the course. And I'm associated with an NGO called Jatan Sanstha for many years now. And I continue to work in the area of reproductive health communication. And of course, I'm a menstrual health activist.
Thank you so much, ma'am. Seheli ji, you can go ahead.
Good evening, everybody. Thank you for the lovely presentations. It was actually intellectually invigorating and enriching. Myself is Dr. Saheli Chaudhary. I am an assistant professor in the Department of Sociology from Belda College. Now located at a rural area, my main motivation for joining this was basically to work with the, because whatever intake or output I will take from this 4-day workshop, I will be actually applying it on my students and work with them. So that was the basic motivation. And also my area of interest is gender, along with technology, reproductive technology. So that was also another motivation. Thank you so much for this opportunity.
Thank you so much. ma'am. Now, Lakshmi ji, you can go ahead.
I just spoke. Lakshmi Murthy.
So sorry. Nikita ji, you can go ahead.
Hello. Hello,
Yeah.
good evening, and thank you for the insightful session. I'm Lakshmi Chetri from Assam. I work for an organization here, and I have been working with women in rural Assam. And yeah, so sexual and reproductive health rights, I have seen that it's very, very important, and uh, there are very few advocates who work on this, and it is an important issue. So yeah, so this is part of my work, and I enjoy doing that, and I feel the need, the importance of this work. So yeah, I have done some little bit of work during COVID. So interacting and interviewing with the women and understanding sexual and reproductive right during COVID, and I've seen that, like, it was neglected. There was no services available, and even now when things are normal, it's not accessing health services are not very easily accessible for women in the rural Assam. So yeah, to increase my knowledge and also to listen from uh, experts like today, yeah, that is the reason I have enrolled for this in this course. Thank you so much.
Thank you so much, Lakshmi ji. Now, Dr. Tane ji, if you want to go ahead. Francie ji, if you want to go ahead with your introduction.
Hello, can you hear me?
Yes.
Okay, I'm Francie Francis, and I'm actually talking to you from Muscat, Oman. And I'm from India. For the past 10 years, I'm working here in the College of Nursing in Sultan Qaboos University. Basically, I am a master's holder in obstetrical and gynecological nursing, which includes women's health. Currently pursuing PhD from Sri Ramachandra, Chennai. And my inclination is towards women always, and that's been my passion. And I'm working for postpartum women in Arab country now. I am developing a mobile application. I came across this advertisement from the LinkedIn, and I don't know what attracted me. I looked into the panel, the speakers, and of course the title and the speakers was my main attraction. So I came in, and I'm not disappointed at all. It's an eye opener for me for being away, and I'm so proud to see that India has been doing so many things, and we have to get updated. And I have got quite a few things from all of you, and I really appreciate all your experience. It matters a lot to younger generations like us. And I will be looking forward to continue this course and any program from your institute in the future. Thank you so much for this opportunity. And this moment is the most personalized one, because usually other webinars don't give a chance to introduce yourself. So I like this. So we get to know each other. Thank you so much.
That's lovely. Thank you so much. Is there anyone else who would like to introduce themselves? Yes, Nikita ji, please go ahead.
Audible?
Yeah, now you are.
Nitika Sharma from Himachal Pradesh University and PhD research scholar in faculty of law. I joined this session because my PhD thesis topic is reproductive right of Indian women earlier my LLM work on the same topic. That's why thank you so much. It's very interesting and knowledgeable session. Thank you.
Thank you so much, Nitika ji. Are there any other audience members who? Yes, Melody ji, please go ahead.
Hi, good evening. Yeah, my name is Melody Khetrimayu, and I worked at Flame University. I have worked at TISS. I have completed my PhD at TISS, and then I became a faculty. So I know Professor Patel for a very long time. She may not know me, but I know her as my senior. And I work on women and gender. And also currently I'm doing a research on menstruation, euphemisms, and gender. So yeah, these are my areas of interest. So I thought, I'll gain knowledge from this course, and from day one. I mean, today is a day one, and I've already gained so much from the three experts. And I'm looking forward to it, and I'm thankful to all of you, all the experts for today. Thank you.
Thank you so much, Melody ji. Is there anyone else who would like to introduce themselves? Sanjeev Kumar ji, would you like to go ahead? Is there anyone else who would like to introduce themselves?
Rinchan Bhutia, are you there? Swati Netrawalkar. Those who can't, okay, Swati, go ahead.
Hello. My name is Swati Netrawalkar, and I'm a counseling psychologist. I do counsel a lot of women, some of whom did have issues regarding reproduction, infertility issues, or going through IVF. So I was more interested in those issues, even at a psychological level. That's the reason I was interested in the title. And I myself have PCOD. For many years, I've been dealing with that issue. So I wanted to understand that at a deeper level. Thank you so much.
Thank you so much, Swati ji. Tane ji, would you like to go ahead? Sejal ji, would you like to?
Hello, am I audible?
Yeah.
Yes.
First of all, thank you for the wonderful session. I'm Sejal Bharadwaj. I've done my bachelor's in political science from University of Delhi, and this year I'll be doing my LLB from Mumbai University. Personally, I found the topic very relevant and interesting, and I saw the brochure and the panelists, such intellectual panelists, and I really found this session very knowledgeable and insightful. Thank you.
Thank you so much, Sejal ji. Dr. R.S. Garindrian ji, would you like to go ahead? Okay. Rinchan ji, would you like to go ahead? With that, I think we've gone through everyone who is in the meeting right now. If we have missed anyone, or if anyone would like to speak later, you can speak in tomorrow's session. You will be given an opportunity to introduce yourself then as well. Now we will be moving to the closing chair remarks. Firstly, I would like to call upon Professor Vibhuti Patel ji to give her closing chair remarks.
Yeah. Thank you very much. First of all, I think I would like to thank all three speakers who put in their heart and soul into it, made an extremely knowledgeable and with presentations with so many learnings, because they have also encapsulated the gist and the highlights of the women's movement and LGBTQIA movements, which have articulated the range of situations in which patriarchal control over their bodies expresses itself, from a husband forcing his wife to have sex to sycophants of population control forcing women to undergo sterilization. Women's movement has always emphasized that women's health rights are human rights. Now it has been accepted by UNFPA and also the reproductive health movement world over. Women's movement has critiqued structures and systems that take away agency of women and sexual minorities over their sexuality and fertility. They perpetuate gender-based violence, of which so many examples were given by all three speakers, and the ideology of victim blaming. We also need to question the double standards of sexual morality and the ideology make our man and boys democratic and respectful in sexual relations. I think that is the common consensus that emerged. Deconstruction of terms such as protective patriarchy, toxic patriarchy, consent, gender identity disorders, unnatural sexual offenses, marital rape. I think they have been very, very important for learnings of today. And I think at the end, I would like to say that bodily integrity and dignity of all beyond gender binary are important. And I think that is the takeaway of today's sessions. Thank you very much.
Thank you so much, Vibhuti ma'am. Now, Dr. Manorama ma'am, I would like to call you upon your remarks.
I think Chair has actually summed it up so well. It was a very meaningful discussion, and especially the question answers that came up also made it more meaningful. And it has been actually very much, constructive dialogue. And I think everyone's contributions are really valued. And I feel that another 3 days we will be having this kind of discussion, and some of the questions which one of the participants said that she was looking forward to PCOD and those kind of issues and challenges. I think those will be also covered in the forthcoming sessions for next 3 days. So it has been very, very insightful discussion, and the panelists were very good. Thank you so much. That's from.
Thank you so much, ma'am. Thank you so much to both our co-chairs for your insightful opinions and perspectives throughout today's session. Now, we will be closing today's session. So as we come to an end of day 1 of Women's Sexual and Reproductive Health Across a Lifetime, an online national summer school program, a 4-day immersive online certificate training course. I, Reetlath, researcher at IMPRI, Impact and Policy Research Institute, would like to propose the formal vote of thanks on behalf of IMPRI Gender Impact Studies Center, New Delhi. We are grateful to our experts for day 1, Professor Vibhuti Patel ji, Dr. Manorama Bakshi ji, Professor Mala Ramanathan ji, Professor Vina Vaswani ji, and Dr. Padmaja Samant-Mavani ji for taking out their valuable time and giving an opportunity to the participants to learn from this online certificate program. We thank all our participants who have raised pertinent questions and actively participated in today's deliberation. Readings for the session have been shared in your email, and a video of the session will also be shared for your learning. We look forward to welcoming you for our second day of this certificate course on 7th May at 6 p.m. We are grateful if you're watching us later on YouTube or listening to us on our various podcasts or reading our publications. We hope you continue to join in to our future IMPRI Web Policy Talk and Web Policy Learning. Wishing you all a very good evening. Thank you so much.
Thank you, Reet, for conducting it so well.
Thank you, ma'am.
Thank you, Manorama.
Thank you.